did one with X-ray once.
The first case I had
Very
done with
difficult.
the X-ray machine. Many I did with X-ray machine. In 92 Pune conference, I purchased my IIT.
I was doing daily 3 enders in the Karnavati hospital. Daily 3. Daily 3. That was the time when I was doing daily 3. Then I shifted to Dr. Our Sa, Parag Shah's clinic down. I had a very luxury because 2 orthopedic surgeons were assisting. Because they were not knowing enders.
Great.
Parag Shah and Sarma Misra. Anand Misra.
Anand Mishra went to London, I think.
They both were assisting. They both were assisting me. So I had a very great luxury at that time.
But I think it needs great understanding of Anders nail in 3-dimensional view to do it in X-ray control. So
Yes.
Kanabar Sahib and Kashyap, they are really so great because sometimes we have seen people who have an ender nail coming out from the fracture site even with IIT. So I think it's so great.
See, because I started arthroscopy, it is a psychomotor skill.
Yes. Absolutely.
In Indus also, it is psychomotor skill.
Yes.
No, all these techniques are skill. If you get it, you will get it in the instant.
Exactly.
Otherwise, you spend years, it is very difficult to get it.
Yeah, Dr. Jigar, am I audible?
Yeah, fine.
Who is
Asif,
there?
welcome.
Okay. Welcome.
Blue boy.
Okay.
Is my mic working?
Yes, your mic is working.
Great.
Your mic is perfectly working, and it's a very beautiful mic.
Blue boy.
Blue boy.
So let me start.
You are the only person with things.
I am making you all mute, and I am starting. Then I will make you all unmute. Okay, sir.
Okay.
Yes, sir.
It is not starting there. Okay. Let me make you all mute for temporary.
You can use the all mute option. Right side. if you
Yes.
scroll down.
I'm using that only. Sir, we at Gujarat Orthopedic Association are very thankful to all the faculties. Warm welcome to all the faculties. I will introduce them shortly. But to the delegates, thank you very much for getting so much response to Gujarat Orthopedic Association webinars. And thank you for attending all 9 webinars. There are so many clicks are coming even before the webinar. Today we got click for enders 1200. Just now it has touched to 1200 clicks. Pre-webinar clicks. So let me introduce you all.
Internet connection.
Please mute yourself, everybody. Please mute yourself. Let me introduce. This is the website you are seeing. This is the website you are seeing at your place. So just check it. Let me show you where you can ask the question. You can see here Dr. Kanabar sir's photo, where you click just the red button and your webinar will start there. And as you go down, there is a window for asking the questions. Just a minute. Okay. Okay. Now it has started.
Yeah, now it has started.
It has started. Yes. So all the delegates,
Again,
there
you
is a
can
window.
re-explain. Navin, you can
Yeah.
re-explain once again.
No problem. That has gone already. But
Okay.
okay, I will re-explain. No issue. Dear delegates, the website you are seeing here is to watch the recordings of Geo live webinars, previous webinars. You can click here and go there without any registration. You can see previous webinars recordings. Here, the present webinar, you can see Dr. Kanabar sir's photo here, and just click here. It will start automatically your webinar here on this page only, the link you have. Now, in between, you can ask the question here. You type the question here and just click the button send. And after sending, it will come to me and I will deliver it to the faculty and we'll be asking your questions. Those who don't want to type, they can record audio in their WhatsApp or they record video in the WhatsApp and just click this button to WhatsApp me. I will send it to this platform and it will come as your voice and video both. Let me introduce today's faculties. Dr. Jigar Shah and Dr. Jawar Jetwa are going to moderate today's session. Both are doing enders and they will show you tips and tricks and they will also show you the biomechanics and the technical tips and the video how to do it. With us, we have a Dr. Rahul Katta from Jaipur. He is also doing enders at the Rajasthan. Dr. Praveen Kanavar sir, he has a lot of experience in ender nailing and he has done already a live surgery and workshop at Varanasi before many years. And Dr. Hembat Mandorwa from Indore, he is also doing a good enders nailing at Indore. Dr. Chintaman Patil, he is from Pune. He has done a good number of enders at Solapur. And we have a Dr. Kashyap Adesna. He has also done and he will be also be critical in some cases for enders. Dr. Nehil Shah from Ahmedabad, he is also doing a very good enders here. And we have a new faculty here, young faculty, Dr. Suresh Kumar from Hyderabad. He will show us what he is doing at Hyderabad. We have a Dr. Kuntal Gajjar. He is practicing senior orthopedic surgeon at Ahmedabad. And he will show us, he will be a panelist and he will guide. And above all, we have Dr. Shiv Shankar from Solapur. He is the president-elect of Indian Orthopedic Association. And we will get a varied experience from the New Delhi itself, our capital, by Dr. Ashish Jaiman. So I welcome you all on behalf of Gujarat Orthopedic Association. So now I will stop sharing and give Jigar to start sharing the screen. Okay? Jigar, are you ready? Dr. Jigar, are you ready?
Yeah, unmuted.
Yes. Sorry.
So now I have unmuted and now I will.
Okay. Start it. Start it, please. Jigar bhai?
Yes, sir.
Speak something so that people come to know you are doing what.
Yes. So,
Open up
good
your
afternoon,
presentation.
friends.
Open up
Good
your
afternoon,
presentation.
friends, colleagues, and respected seniors. Hello.
Yes, open up your presentation. Carry on. You open up your presentation.
Okay.
Yes. Open up your.
I am
open
audible
up your
now. Okay.
presentation.
Yes.
Yeah, I am already open.
Oh yes.
Yeah.
Fantastic.
So I am starting now. Good afternoon, friends, colleagues, and respected seniors. I am Dr. Jigar Shah from Ahmedabad. Today, first of all, I would like to congratulate Dr. Navin sir for arranging this so much of webinars and converting this idle time of lockdown into a great academic time. I would like to thank him to give me the opportunity to speak on Anders nailing, which is one of my favorite topics. Anders nailing has not been much discussed in the armamentarium of proximal femoral fractures. At this point, I would like to quote Dr. V.M. Iyer Sahib, one of the most experienced orthopedic surgeons from Solapur. He has always encouraged me to share my views on ender nail on different forums. He is the one who led me to NailsCon 2019. Let me quote Dr. V.M. Iyer from Solapur. He told that I have observed that in all discussions on adult proximal femoral fractures taking place on different forums all over India, ender nailing is never discussed. This was the 2019 NailsCon program. It was only 10 minutes for ender nailing, 4 hours of proximal femur session. So he told that except in Gujarat state, Anders nailing is not the usual management, particularly for adult proximal femoral fractures. After having seen the results of ender nailing personally by expert surgeons, after having conducted a workshop at Solapur done by Dr. Jigar Shah and Dr. Rakesh Shah with live surgeries, and after seeing the surgeons who were initially not much familiar with Anders nail, but were able to do the same successfully after having attended the workshop. So I was convinced that this technique should be learned by every orthopedic surgeon. And I thought NailsCon being conducted annually was the best platform I could talk about Anders nailing in adult proximal femoral fractures. So this was the view of Dr. V.M. Iyer Sahib. And with that, we'll start the discussion of Anders nailing. So let me first of all tell that what are the indications of Anders nailing. It can be applied to all types of intertrochanteric fractures of Evans classification. That's undisplaced fracture, displaced 2-part, 3-part, 4-part fractures, and a reverse oblique fracture. Subtrochanteric fractures, all type 1, 2, 3, 4, 5, 2-part, 3-part with a butterfly fragment and commutative 4-part and with the GT fracture extension. These are the images of those fractures. And the problem is not with the stable fracture. Almost all the implants work well with the stable fracture, but the problem lies where the fracture is unstable. So what makes an intertrochanteric fracture unstable? So there is an article in Journal of Orthopedic Trauma in 2015 that the posteromedial comminution, reverse obliquity, intertrochanteric with subtrochanteric extension, intertrochanteric with avulse GT, and a lateral wall breach. These are the criteria for instability. So this should be the criteria we have to keep in mind while doing any procedure with any implant. So with this, I'm now starting with the other topics, and thank you for introduction. Navin sir.
Yes, go ahead.
So now we will start with the
Escape this PowerPoint, then start
Yes,
new
yes.
PowerPoint if you have different PowerPoints.
Yes. So now straight away we'll move on to the tips and tricks of the surgical technique of Anders nailing.
Okay, go ahead.
So whenever you feel that I am not audible or something is not seen, just
No.
please tell me.
I stopped your video because your signals were weak, so I stopped your video so that at least your voice comes. Whenever your
Okay,
signals
fine.
will
But,
be stable,
and
I will
the-
make
and
your
the-
video on, because now everybody
Yeah,
has
that's
seen.
fine.
Everybody has seen you, so
Yeah,
everybody
that's
knows
fine.
you.
That's fine. Yeah, that's fine. That's fine. But the PPT is running well, no?
Yeah,
Yes.
it's going
Yeah,
very
carry on.
well. Now tips and tricks has
Fine.
come already, sir. Yeah.
Sure. Okay. So let us start with the tips and tricks. The
Make it full window, green color green color in your Mac. Full. Make this file full. PowerPoint so full. Left hand side upper.
3 dots.
3 dots. Oh, you stop sharing. You stop sharing, Jigar bhai. Are you audible?
Just a minute.
Yes.
Yeah, I am audible.
Issue. Okay. Then share screen again. No issue. Share screen again. No issue. Why you stop share? Don't stop sharing. Just make that. Just make this PowerPoint full. There are 3 buttons: green, red, and yellow for your Mac.
That's fine. I already make it full.
Just click it full. Yeah, that's all. So
That's full now.
So now your lower tray will go. Okay, fine, fantastic.
Yeah, that's fine. So then sometimes people don't take a lateral view, telling that the patient was having pain, but I always take a lateral view because little preoperative pain saves from much postoperative pain. So if there is only AP view, and if you see something like this on the IITV, then it will be real scary. So taking a lateral view helps in anticipating the problems in reduction, number of assistants required, and we can plan the reduction maneuver as well. A long X-ray should be taken to see the canal size for prediction of the number of nails and required to jam, and we can see the bone quality as well. When we see this kind of X-ray, the questions come in our mind are: what is the comminution? How will be the reduction in lateral view, and what will be the status of the lateral wall? As soon as you take a traction view, you can see all these things, and it will solve all your queries. So a traction view is also much important. This is another example of a fracture which was quite displaced, and the traction view will give you relief. This is the instrument set what I am using. I keep 4 nails of each size of 4.5 millimeter diameter in my set. That also includes
go ahead with the slide. We are not able to see instruments here. Go ahead, slide. Yeah.
Yes.
You are not changed the slide.
Okay, fine.
Okay,
fine. So this is the patient positioning. The patient is on fracture table. Surgeon stands in between, and the IITV comes from the front. This is very important to understand. When we start from the medial side. So when for a right side surgery, when we start from here, and if I do external rotation of the nail, then it will go into the anteromedial compartment. And if we see only AP view, then we have to imagine in our mind, then the nail is going in the anterior compartment in the lateral view. The same way when we rotate it internally, it will go into the posteromedial compartment. If you rotate it more than 90 degree externally, then it will go into the anterolateral compartment. And if you rotate it more than 90 degree internally, then it will go into the posterolateral compartment. So this is very important to understand the three-dimensional view of the ender nail, where it is going. Valgus reduction. See, most of the proximal femoral fracture fixation fails in varus.
Next slide. Click the next slide. Next slide. Click the next slide, please.
So, so valgus is very important, and an accurate reduction should be achieved before starting. But with ender, a little mal reduction can be corrected. Suppose if the shaft is sagged posteriorly, you enter the nail into the proximal fragment, and as soon as you will rotate your nail posteriorly, it will bring the shaft in line with the anterior cortex of the proximal fragment. So this can be done with the ender's nail.
So it can work as a reduction tool also.
Yeah, it can work as a reduction tool. So accurate reduction is must before starting, and you just can't accept this and go ahead pushing the nail. So this is not acceptable. So let me show you a case that this was the 71-year male and comminuted subtrochanteric fracture, where when the reduction was not there, there is no hesitation to open it and get a good reduction. And ultimately it was fixed like this with very nice reduction. And this was a 3-year follow-up. And the gentleman at the age of 74 is still able to sit cross-leg on the floor with full range of motion. And one can see that there is no external rotation deformity as well.
Go for the slide so that we can show the results here. Fine.
Yes. So let us see.
You can show the video. Click the video. Yes. Go back. One slide back.
Can you see the video now?
No. Go back because okay. Now we can see it. Okay. No issue.
Click on video.
Click on the video, or your internet.
The video is running with me.
Okay, so it is the internet connection is slow with you.
Yes.
Okay. No issue.
Fine.
The people
So
delegates have seen the video now. Okay. Go ahead. Entry.
So the entry is taken at the superior pole of the patella. This is the entry. At present, we are taking the entry to around 1 centimeter of incision. And this was the patient who was operated around 10 years back with an incision of around 14 centimeter. And this is our current incision, which is of almost 1.5 centimeter. Can you see the video now?
No, still go ahead, because you are not clicking the slide for us. Yes.
Jigar,
Or
you are having the presenter view. You have got 2 slides to see, but we can see only.
No. The presenters will not work here. If he is a presenter view, we will be also seeing presenter view.
It is probably only because of the net speed.
Net speed.
We just keep on doing this. That's all.
Okay.
That's all.
So let me check another net.
Little go slow. No, don't check it. Go slow. That whenever you come to the point, it will come automatically. Little slow. Your speech. Pace should be little slow. No issue of time. Don't worry.
Yes, there is no. See, with these webinars, the advantage is that there is no, that red button and tickling. You have to finish up in 10 minutes. You can go slow. That's all.
No purging.
Sir, is it audible?
Now
Yes.
it is audible, but you go next slide for the video. We have seen the entry 1.5 centimeter. You go next slide.
Yeah. Sir, I can see the video in my desktop.
Yes,
I think you are not being.
Okay, no problem.
Yes.
So that's why I say go slow. Okay, fine, fantastic. You are taking entry.
So, have you seen the video of entry?
Yes.
Oh, that's fine. Okay, fine. So let us move ahead. So this is bending. We give a 10 to 15 degree posterior bend at the lower end.
Go next slide. Yes. Start this video. Okay, it's going slow because of your
Yes, it is there.
internet speed.
Keep
problem.
it there. It will accumulate all the data and then it will.
Start. Be
Yes.
slow, little slow. That's
fine.
all.
Okay, fine.
Don't be in the hurried mode. Don't worry.
So I'm playing it again.
Okay, you play it again. Lovely.
So this is the posterior bend.
Yes, very good. We can see very good posterior bending. Yes.
And
Posterior
then
bend.
the ender is rotated, ender is reversed, and now I am giving the anterior bend at around 1.5 to 2 centimeter from the tip.
So Jigar bhai, you give posterior bend
Yes.
to the inferior end of the ender or the proximal end?
Inferior, lower end.
Lower end.
Yeah,
eye.
just because you need to speak that, because there are many people who are not aware of anything about enders.
Yeah.
Yeah. That's what I told initially, that the posterior band is given at the lower end,
Yes.
and the antiversion band, that's an anterior band,
Yes.
is given at the tip.
So,
Okay.
Okay.
you have to speak a few important points 2, 3, 4 times.
Yeah. That I don't have any problem with that.
Yes.
Okay, go ahead, sir.
So this is
Yes.
the lower end,
Go next. Yes. Lower end.
and then the anterior is located, and this is the tip where I have given the anterior band. The video is also running a little bit slow because of, I think, the net connectivity.
Yeah, net connectivity is a problem at your place, or you may have a
And this is the
mobile.
medial band. This is the
Yeah.
medial band. Positioning of the nail. Start the first one resting on the calcarean AP. Can you hear me, sir?
Yeah.
Yes,
Everything
yes.
is okay.
You continue.
Yeah, that's
If-
fine.
If only problem, then and then we'll speak.
Okay, fine, sure. And the first nail should be resting on the calcarean AP view and anteriorly in the lateral view. And then one can fan all the nails accordingly. And should be the final picture. Reduction with nail joystick. So ender nail probably is the only implant which may help getting reduction. All other implants need prior absolute reduction before fixation. So passage of each nail will correct the translation just like this, that this is quite displaced, but as soon as the nails will pass in, it will reduce the translation, and the anterior cortex will fall in place. External rotation deformity. See, previously the nails were used without bending, so that there was much problem of the external rotation deformity. But now when we bend the nail of around 10 degrees at the tip and 15 degrees retroversion at the lower end, it gets a shape of almost an hook, and that prevents the external rotation deformity to a large extent. So I will show that in my other videos as well, that patients don't have much of the external rotation deformity. There is a blind spot in IITV when we do ender nail. Even after showing AP and lateral view, there can be a little a blind spot. So after completion, one should see it 360-degree live in IITV.
Okay.
Jamming the canal. When we use, I use minimum 4 nails in almost all cases. Out of 180% cases are more than 4 nails or 4 nails. So whenever there is more a wide canal, I use a short nail which adds proximal to the fracture, that adds in jamming, and that adds axial as well as rotational stability. Fanning. By fanning, we mean that one should be able to see all the nails differently in at least one view. So that is showing catchhold of the proximal femoral fragment, the femoral head. That helps in maintaining the reduction. Subchondral hold. Tip apex distance should not be more than 1 centimeter for at least 3 nails for maximum hold. Bailout prevention. See, this was one of the most common reason for which ender nail were dropped from the armamentarium of proximal femoral fracture. What I do is I push the nail with the next nail inside the medial femoral cortex. So here you can see the nail. I have pushed the nail inside. So at last, my terminal impactor will rest in the air, and that suggests that my all nails are inside the medial cortex. And this is how I push my nails. Can you see the video, Kashif?
Yes.
Fine. So this is an animated video. This is the entry hole. The ender is pushed in. That is the fracture site. The nail was pushed in. It does not go that much in. That is just an animation. See, when the fracture gets collapsed, the nails will go down to the entry hole. So now for the same nails to come out from the same hole is very difficult. And with collapse, the enders will go down in the medial femoral condyle rather than they will come out under the skin. These are some other methods used by people. They make a U bend of K-wire. Some people use 3.5 mm screws, but I usually don't fix anything lower down, because what I feel is when you lock the enders lower down, with collapse of the fracture, they can pierce the joint. So it is better to avoid joint penetration rather than they come out. Neutralizing the valgus abductor force. This is particularly very important in cases of lateral wall instability, just like a reverse oblique fracture. One can always put a lateral nail either from a medial or a lateral entry. Let us see a case. This was a long spiral comminuted subtrochanteric fracture. And this is 4 nails are medial, and 1 nail was from the medial entry only into the going into the greater trochanter. So this is the final.
Yes, yes, we can see it.
Yeah. So another example, this is 68 female, 4-part intertrochanteric with subtrochanteric. Greater trochanter was a separate fragment, and this was fixed like this, all the nails from medial side and 1 nail from lateral side. And this is the final lock, full union and full range of motion. So to keep in mind some minor points, release the traction after nails once the fracture looks stable. Don't miss the terminal impactor hold on the eye while inserting the last 1 or 2 centimeter of the nail, because once missed, it is difficult to get good hold on it. And check a 360-degree view to avoid blind spot. If you penetrate the cortex in the shaft, take the nail back about 5 centimeter and then again insert it and then rotate and insert in a new track. And whenever you are inserting all subsequent ender, introduce in a different track till you bypass the cortex hole. Otherwise, the ender may come out from the same hole. Post-operative protocol that includes derotation boot for 2 weeks, corticeps drill from day 1, sitting is allowed from next day, and discharge on the next day after dressing. We discharge the patient in less than 24 hours of time. The average time to knee mobilization is 2 weeks. Now we are trying to reduce this time. Average time to weight bearing is around 3 weeks. Before that, we take a check X-ray and see the stability of the fracture and all the implants are in good position. Let us see another difficult situation to start with. See, these were the IITV images to start, even after traction on fracture table. The shaft was medialized in AP and posteriorly sagged in lateral view. So the ender was rotated more than 90 degree to anterolateral compartment to enter the neck. The shaft was added and pulled laterally, and the first nail was entered. So this was the final sitting of the first nail. This was the entry of the second nail. It was still going lateral and posterior. This is the final sitting of the second. This is the third nail. Now it is going a little bit medial. This is the final sitting of the third nail. And the fourth nail, as the previous 3 nails were more lateral and lateral posterior, I have tried the fourth nail to get it in the medial and anterior compartment. So this is the final sitting of the fourth nail with good fanning and good valgus. So a fracture which was looking very much scary on first look or even on IITV, that gives with Ender's nail you can get a very good reduction and very stable fixation from just a 1.5 or 2 centimeters incision. To have an example, this was the live surgery case which was performed by me at Ahmedabad Orthopedic Society CME. This was 3 weeks old intertrochanteric fracture of 55 mil. This was the traction view. This was the immediate post-operative X-ray with 4 nails and good fanning. One can see all the nails are inside the medial cortex. And this is the video just at the interval of 1 month or 3 weeks. See, there's no external rotation deformity at all. Can you see? Can you recognize it, sir?
Yeah. Start the walking. Start the walking video. It is going a little slow. No problem. We'll see gradually.
Yes.
Can you see there is no external rotation deformity?
Yes, we can see it very well.
So this was the final follow-up, and this is the final 10 weeks for full range of motion, and hardly one can see the incision site. So another 1 or 2 example of unstable fractures: the posteromedial subtrochanter, IT subtrochanter with posteromedial fragment fixed with Ender's nail. This is the final follow-up with full union. Patient is able to sit cross-legged and squat as well. Can you see the video, sir?
Yes, we can see. He's squatting. He's squatting. Now he will be climbing and down climbing. Start it.
Yes. So this is the way he is going down and up.
Fantastic.
The unstable fracture, that's a reverse intertrochanteric fracture, fixed with Ender's nail and a nail in the greater trochanter with good final union and full range of motion. Removal of ender nail has been asked a lot of time. People always ask me that once you push the nails inside the medial cortex, it is difficult to remove them. So a lot of people ask me that, and Dr. Nimish sir particularly were asking me about the removal video. So I am always telling him that it is not a big problem. So to understand that distal femur is trapezoid, here my owl is exactly on the skin, but still if we see on IITV, it will show that the owl has pierced in. So the same happens with the ender nails also. When the ender nail are over here, people will feel that it is quite away from the medial cortex, but it is actually not like that. It looks like that just because of the trapezoid shape of the femur. But when I take the owl little bit posteriorly, it will show like this, that the owl is on the outer cortex.
Next slide.
Here,
next slide. We are not able to see the next slide. Go slow.
No. He explained.
Yes, now we can see next slide. Yes.
Can you hear me now?
Yes. Yes. We are hearing, but the slide comes little late, so be slow. Next.
Okay, fine. Mismatching.
Yeah.
Okay, fine.
Go next.
So this is fine.
This is fine. Fine.
So here one can see the ender nail over here. Here is the medial cortex. When I put my artery forceps over the nail over here, the IITV picture would be like this, that it will show that the ender's nail are quite inside the medial cortex. But actually the artery forceps is just beneath the skin, lying over the ender. So it is very easy to get these nails out. When indicated for non-union or any other reason, a 1.1/2 centimeter cortical window, half at the level of the nails at the eye level and half below the level of the nail tips is done. A cortical window is done to have the space for the extractor to enter inside and get a space for hooking the ender eye, so that it will give some space and you can remove the ender quite easily. One can also have a small homen lateral to the nails inside the canal and pull out the tips nearer for easy engagement of the extractor. As soon as we remove one nail, the rest becomes loose and easy to remove, as some space is created for extractor to get into the nails. Total knee replacement after ender nailing, I don't have any personal experience for this, but it is easy to remove nails from medial cortex, medial entry from the same midline incision of the TKR. It may be possible to introduce the rod of the zig with enders in situ and go ahead to, one can use to have extramedullary femoral zig as well. There are some advantages of enders nailing. That's a minimally invasive with zero infection rate and a very minimal blood loss. There is less anesthesia time, less operative time, and less risk involved, less morbidity, less need for post-operative ICU stay. Can be done with a lot of ease in obese patients. There is much difficulty of taking entry in PFN, and too much wide exposure is required for DHS, angle blade plate, or LCP with high chance of blood loss and infection. For unstable features, the risk of breaking the lateral wall during entry of PFN and triple rimming for DHS is very high. While we are in enders, we are not touching the lateral wall at all. It works on the principles of musculotaxis, so that enders works really very well in those cases. A stress riser effect is not possible with ender, while it is much possible with PFN or DHS. Osteoporotic patients being intramedullary implant, load-sharing implants, enders work best as in osteoporotic patients as well. It leaves behind a virgin proximal thigh and proximal femoral bone, even if a second surgery is required. In terms of cost effectiveness, the total implant cost is hardly 2,000 rupees. Indian implants cost for around 5,000 to 6,000 rupees for DHS or PEN, and imported implants cost for even 30,000 to 40,000 rupees. Stay is hardly 24 hours after ender nail. The medicines used are very less. So overall surgical cost to the patient is huge savings. I have uploaded my technique on YouTube as well. So the important steps to remember are reduction, pre-bending, Sir, can you see this slide?
No, go ahead, go ahead, go ahead.
Yes, yes.
Now,
Can you see the slide?
now we can see all the 7 things.
Yes. So this is the rainbow. These are the different colors of rainbow, and one can keep all these 7 things in mind to have a successful endo surgery. These are focus reduction, pre-bending, a good bending of the nails, jamming, fanning, subchondral hold of the nails, and bury the nails inside the medial cortex and neutralize the valgus abductor force in case of lateral wall breach. So these are the important points to tell you. Thanks a lot. Thank you.
Okay, now you are going to show the video technique.
Thank you, sir.
Are you going to show video or not, sir? Jigar
Yeah,
bhai,
I can show the video well, sir. Yes.
You complete your video, then Dr. Jawar bhai will go with the basics of biomechanics and I think his experience of femur. Meanwhile, if anybody wants to ask the question within the faculty can ask. Kanavar sir or Siva sir. Siva, there is a question from Dr. Siva. There is a question from Dr. Mohan Mantri.
Yes.
He is asking that what is your say comparison of PFN and enders. You must have experienced both, Dr. Mohan Mantri.
No, I have not done enders in the recent past. In the late 90s, I did few cases, and because it backed out into the knee, then I stopped doing it. I might have done about 5 cases in the late 90s after.
But backing
yes.
out, you had done an anterior bending or posterior bending? No.
No. I
Not
had just
at all, right?
taken the entry.
So these are the all refined. These are the all refinements in the enders nailing. Previously, we were backing out and all problems, external rotation were there. Now this group has refined this. Dr. Jawar Jetwa and all this Ahmedabad, they have refined everything. So with the refined Dr. Mantri, there are different results. So this webinar is to show us what are the refinements in the ender nails. So that question is answered probably.
Yes. Kanabar sir wants to answer. Yeah.
Navin,
Yes, sir.
Yes, sir.
I think we must let the people who are saying this web seminar, the posterior band is for what purpose? Why are we doing the posterior band?
Yeah.
I am going to show everything.
Because anyway, Dr. Jawar Jetwa is going to show the biomechanics, and then if that questions are answered automatically, then if question remaining, we'll answer the questions.
So my request, let him complete his lecture.
Yeah. But in between time, the adjustment, we can take 1 or 2 questions. That's why.
Okay.
Navin sir.
Yes, sir.
Jigar, will you directly insert the all, or you take some drill bits or anything prior to entering the owl?
Yes. There is a question, Jigar bhai. Hello, Dr. Jigar, can you hear us? Where he has gone?
Jigar is unmute.
No. It's not unmute. Just ring him. He must be adjusting his internet connection probably. Because his presentation is there. His presentation is there already.
With 2 centimeter incision, he is not.
Switched off his video probably.
He is putting.
No, his video is here only. Jigar bhai, share again if you want to share. Otherwise, we can switch over to Jawar bhai. Then you show the video.
No. Sir, I think it has been on now.
Okay. Now we are not seeing it. Now we can see it. Very good. Please go ahead.
Okay, so let me the edited surgical video.
Okay.
So this is a 71-year male with a simple intertrochanteric fracture. This is the patient position. Legs wide apart.
Go slow because video is coming slow. So you remain slow. Whatever you are seeing, we are seeing little late. So go slow, please. Now we are seeing the patient pre-op X-ray and patient's photo of male 71.
No, what will happen? Only some part of his video will come and transfer. Otherwise,
yes, that's correct. So meantime, what I would suggest is Dr. Jawar Jetwa should start doing his lecture.
Jawar bhai, Jigar bhai, send me the video. I will download and I will show from my screen. That will be easier.
Yeah.
Also, if Jigar bhai can make arrangement for High speed net. Yes.
No. High speed net may not be possible, but send me the video. Till that time, we switch over to
Navin,
Dr. Jawar Bhai. Yeah.
Navin, YouTube link is there. You can ask the YouTube.
I know.
YouTube link and yeah,
I will manage that part. Jawar Bhai, can you share the screen?
Okay, okay.
Jigar Bhai, send me the link
So
only
now
of
this
YouTube.
is-
If you're not edited after that,
I
send me
think
the link.
let me try it with my hotspot. Another.
No. Now
No,
the Jawar
hotspot
Bhai has
will be
started
more
already. No, don't go on hotspot.
Okay, fine.
Send me. I will run and you speak it on that. No issue.
No
best part is let it go to Navin, and Navin has a very high speed.
I
so
have
we'll be able
300
to see-
Mbps. I have 300 Mbps line.
So that is a good thing. Okay.
Fine.
So now we are starting with the yet it has still not started.
No. You started. Click your this symbol. Make it full screen. Yes. Now it has started. Very well.
Okay. So
I think your
good afternoon,
connection is
everybody. Okay, and lot many things I have to say because many things were in a problem, and then what more can we do? So let me go into the basics of biomechanics that we know that all is well when it is two-part fracture. So it is not in replacement of any of the other implants. You are using those implants and everything is fine. The trouble starts when it is unstable variety, and the trouble is also with the endonase as well. It's not like endonase is not going to give you trouble in a three-part fracture. So some of the modification, some of the more understanding has been with this. Now, let me go to the published literature that endonase mechanical stability has been already has been checked before. It is 18% stronger than the single hairy snail, and the torsion, which is much lower than other nails, but this torsion is not that much low as required by the body. So for the body, it is a good sort of like comparison with this. The force of the body weight which is required, the endonale is much more than that. That has been published. Now, very important thing is that special elastic alloy is a very important part of the nail. It has a stable elasticity after autoclaving even. Its elasticity is equal to the bone, withstands micro motion without fatigue, and it stimulates new bone formation. And up to 20% of the bending you can regain. So more than that, if you are bent, it cannot be regained, but up to 20% it can be regained. Now, what Kemp says, whatever the type of pertrochanteric fracture, the synthesis brought about by endonales lead in a large minority cases to a solid fixing. This was one. And he said, if there are complications, faulty positioning, bad positioning of the fracture, pinning site, length, insufficient fanning, all these are the problems of complication rather than it is the implant. Now, we just cannot forget or just bypass this particular publication, 2,137 cases with 10 different hospitals, nearly no contraindications, no case of non-union, no case of a broken nails, such a huge study. We just have to say, wow. So then why it has been stopped by now? It was very much in 90s, 80s and 90s in Europe, because commercially there was no push. It was at the bottom list. Surgeons contracted the indication. And some improvements we required because there were some complications which are off and on. So now the applied classification is that if you have an intertrochanteric fracture, if the pre-direction is stable and post is stable, then you can go with the conventional implants with proper method. But pre-direction is unstable, then rather to go for a best reduction, or you have to think of a biological smart fixation, which I'm going to explain how it works. So basically, BSF is for all fractures, and we are going to now discuss about subtrochanteric and the intertrochanteric fractures. The mechanobiological challenges in the fixing unstable intertrochanteric fractures are very important. Now listen to this very carefully. Basically, we have something in the proximal part that is the head, where we want to have a good hold. And there is a distal part, which is the shaft, where we want to have a good hold. So the basic thing is to have a two good holds, and rest of the in between you can forget. but we need a control collapsibility because there is going to be some collapse. So we need some implant where we have a very good hold on this proximal part, very good hold in the distal part. And we have to see that good reduction is there, which includes anteromedial border, neck shaft angle, anteversion. All these things added with the challenges of osteoporosis. This is the basic aim or objective what we want to do in any intertrochanteric fracture. So we know in any intertrochanteric fracture, irrespective of the classification, there are two things which are consistent. There is an intact proximal head and neck, and there is an intact subtrochanteric or below that a shaft. So two things are very easy. Now in that case, we have to see that what you do, get a good reduction, then have a proximal feet hold and a distal feet hold, and the job is done. So how you can have increased the proximal feet hold is by adding with the CC screw. So the elements of biological smart fixation is a 7 mm. Please remember, not 6.5 mm. 7 mm or 7.5 or 8 or 8.2 mm. All these CC screws are available with the first contour nail, second contour nail, third contour nail, and another CC screw, which is called as a turbo screw. So what happens with other implants? When other implants are used in the neck region, which I again said we want the hold of neck and head, the neck comes first. That is around 20% to around 36% with the different implants. And when you use this ender nails with 2 cc, the occupancy is by 4.5 nails plus 2 7 mm screw. So it adds up to a very big amount, the area of the neck, up to 54% is occupied, you can say surface point of view. Now, when you go on adding the nails or the screw, the medulla starts compacting more and more because it has to displace. So wherever you want an impaction bone grafting type of a hold, it happens automatically because you are displacing the whatever available medulla inside the neck, and you are putting so many implants, 4.5 mm plus 7 mm, 7 mm. Compared to any other implant, this is the highest metal you are putting there, and that also elastic. So if you just consider the surface area with the different implants, you know the endonail is occupying a large area for the fixation of the proximal fragment. Now this is very important. None of the implant is having anteversion. There is nothing like right-sided DHS and left-side DHS. There is nothing like angle blade, which is right or left. Even prosthesis is also not right and left available. So how can you do it? The problem is that once you once you want an anti-version, you require something which can be put into the head and neck this way. So something, it has to come out from the medulla rather than from the lateral cortex. So this is the point. If you pass something which is in a red size, if you pass that particular nail, you will be able to pass posteriorly. If you want to pass in the center, you have to go a little posterior. So the point is that you have to have some sort of a nail which can be passed from the posterolateral side, and then you need such type of a screw, which is obviously not possible. All the screws will be straight. You can't pass a band screw. And this is how the endonails works in a best way. This is the screw, which if I want to pass, I have to rotate. That is not possible. Now in the slit, if you can see, this is the slit, where there is a posterolateral slit, from where if you pass any of the implant, it's going to have a loose sort of a fixation on the lateral wall. So what you do is, you pass from the intact area 2 cc screws, and you catch hold of the distal with the proximal, and you can avoid the slit. So the basic lateral wall issue is no longer there. It's an absolutely no lateral wall issue, right? Now, this is something which is analogy, like what you see clamp in the railway track. Those clamp, there's one is outside, one is inside, much in the same way. When you give this posterior band on the distal part and the anterior band, the anteriorly from inside of the head, it is going to give one sort of a hold, and the distally it is outside and that way it is not going to allow any sort of rotation. So it is a elastic hook clamp which happens when you have a bent nails. Now enhancing the press fit hold, what we can do is pass another CC screw and target the tip of any of the nail or maybe between the two nails. And when you target like this, it actually bends the tip inside, by which the total hold of the head and neck increases. And this has worked in a very good way, thereby much or the larger part of the patients where the backing out was a problem has been solved out by this turbo screw. Now let me talk about the subtrochanteric. We all know there is a 30% to 15% cutout with a malunion, with an intense varus force and everything. So we know that there is always a large dynamic cyclic varus force, even after reduction and fixation. And if this is the situation, if you have a large dynamic cyclic varus force, then the answer is very simple. If there is an action, you have to have counteraction. And the counteraction is by putting nails on the lateral side, and you create a large dynamic cyclic valgus force. So that way it can make some difference. So this is something to represent that when you pass these nails, once you pass the lateral nail, the varus force is neutralized. And I call this as an energized stability by dynamic valgus force. And this is the way it holds the subtrochanteric fracture very well with the valgus. Now let me give some few illustrations how this works. Say for example, this is a fracture which is unstable and it has been made stable with complete union. Just don't overlook such slides. Think of it's just not a fluke. Something is happening inside. Something is working inside. And this particular dynamic valgus force nail inside of its own elasticity is not allowing any varus collapse. Much in the same way, these are the cases where ambulation can be on the second day, non-weight bearing after 1 week, and weight bearing after 6 weeks, and you can have a very good hold in a subtrochanteric fracture. This is the way you go on fixing such fractures. And since this is a recording, anybody can go slow when they see the recording. But just for the sake of this, I'm going very fast. And this is the way where if there is a slit, posterolateral slit, if you can see on the lower part of the picture, that particular slit is the position where you pass all other implants. So you need to avoid that slit, and this can be done with this type of implant where you have something very good, where even if you want to support the lateral wall, you can support with the screw. So this is the way the whole biomechanics of unstable even after fixation is taken care of. Now look at the first X-ray. Is it possible? Is it possible to do a close reduction with a couple of sutures only? And this is what has happened. Once you fix, and here what I have made it that I have strengthened the lateral wall by passing one CC screw. That is again 7 mm. That is again going into the very good area of the calcar and in between the nails so that it can displace the nail. This is after 8 weeks, and this is what is happening. No varus collapse after 16 weeks. Look at the movement. So what is very important is that such a fracture, without giving so much of a soft tissue dissection, without disturbing or increasing more surgical trauma, you can get away with a very good. These are another cases where same way you can fix it and patient is allowed. One more case where you see subtrochanteric, and I have attended number of conferences across the globe, and I always feel so much pity when I see a subtrochanteric fracture failure. This is the one implant which you can blindly go with in all subtrochanteric fractures because it has a biomechanical base on this. Now look at this another case where it has been fixed very well. You can see this. Here you can see how I have reduced the fracture best way, and then as of course, in any case, you have to have a good reduction. There is no compromise on that. And then you can go with 300 nails and with a turbo screw. And this is the way you can fix it very well. Now, these are the cases, reverse, heavy patient with so many comorbidity. So once you put, there was also a small fracture in the lateral wall, but once you put a CC screw, look at the final result. Look at the total anatomy which has been restored and the patient is walking. All other implants might have given so many problems with an old age, with obesity and with diabetes and whatnot. And these are the cases where you are able to fix it so well and get the final result like this. Some of the cases where patient may be very old age, they are doing very good functional movements. Sometimes it happens that your nails are not right into the subcortical region, but because of this turbo screw and CC screw, the nails are hold because we want a maximum occupancy in the neck rather than the head only. So now, what I'm going to explain is already on my YouTube video where there is a step-wise everything is written. Basically, there are 5 bands which we give in a proximal femoral fracture, 2 in sagittal plane, distal posterior band and anterior anteversion plane, then 3 in the coronal plane. One is a proximal, neck shaft and a distal gentle curve. So what happens with this? Kuntal, I think your voice is coming. Okay. So what happens over here? The first one, which is a posterior curvature, is basically for anti-rotation and also is to avoid any irritation to the knee joint. The second curve which is given is the anteversion curve where you try to maintain the anteversion as well as it helps in rotational stability as a hook, which I have already explained. The third one is the tip. If the tip is bent proximally, which is only a 5 mm area, you will be able to get a very good hold on the medial quadrant. And then there is a particular, a very gentle, soft angle at the neck shaft, where you try to go near to the calcar and have a better hold. And don't forget to put this generalized curve at the shaft. This generalized curve has made a big difference because it is now not allowing the getting back of the nails. So it's a good thing. Now, you see many of surgeons in Ahmedabad, they are doing now forget lateral wall fixation. You have seen that Jigar also has done the same way. So what exactly is the forget lateral wall? This is a case where everything is unstable, poor compliance, heavy smoker, huge swelling, episode of pulmonary fat embolism occurred in 3rd week. So many problems with this are multifragmentary. So what is done? Simple nails. Now, how come it works? What exactly is the biomechanic? How come it is possible to go with an active, pain-free internal rotation, which is on the 2nd day? And this is at the 8th week, full hip movement, full weight bearing, no external rotation attitude. So the things which are happening, this is the same case at the 18 weeks. Look at the lateral view. Look at the original on the left corner, the original fracture, and the final one. You just have to think of, is it of the same patient or other? This happens when you have a forget lateral wall fixation, where again I have said that this is the fracture where there are multiple fragments like 1, 2, 3, and 4. The moment you give traction, they usually fall in line with the maximum possible reduction. And this is the way you get maximum possible reduction. But the final part occurs when you put the nail from below. Because when the nails are pushed, when they reach to the subcontinental region, where there is nothing like you have done drilling, you are just pushing with the hammer. So there is a non-return axial push with musculofacial ligamentotaxis. This is something which happens in so many cases. And this is the reason why you are getting such a good result. So again, it is the best hold in the head and neck and best hold in the below or the proximal shaft. This is going to work. So press fit hold at the isthmus and press fit hold at the neck is the thing by which we are getting such a good results. This is a very important figure. It shows all the attachments on the proximal femur, all glutei and all rotators and so many things you can see. So what is happening? When you do a proximal femoral nail, when you put in any entry, there is an injury to the medial circumflex femoral artery and injury to the all insertion of these nails. So what does the literature says? Literature says that up to the 53% of the patients are having a substantial injury, not we can just neglect because of these particular entry. And this is with the very good study of the ball sport. The ball sport says these are the muscles. Keep those muscles there only. Don't erase it and put some implant, because there is no space available on proximal femur where you can pass proximal nail. The ball sport is much anterior, is much lateral, and what we are doing, usually doing is all puncturing all these muscles in that insertion. So this is one more case where you can look at this. You just can't think of what is unstable part, how many fragments, what is the, how will you get and how you get the hold. And this is what is happening. You are able to fix it so well. This is again because of the turbo screw, because of the CC screw, because of the ligamentotaxis, because of the bands, and so many things it works, and you come out with such a bad situation so easily. So this is the versatility of ender nail or ender nail with the CC screws. So friends, there was an era of rigid fixation. There was an era of flexible fixation. Then the motion lock fixation came. And now this is an era of happy fixation. And what do I mean by happy fixation is that there is a preservation of biology and the muscle power, incision in healthy area, no intra-articular entry points, minimal surgical trauma, smart indirect reduction, exceptional hold in the head, press fit grip with the dynamic inside-out forces, no stress riser, implants as per the reduction rather than reduction as per the implant, micromotion induces callus, controlled collapsibility, and very rarely there is infection, non-union, or a fat embolism. So this is what gives you happy fixation. You are happy, patient is happy. The whole detail of this technique I have uploaded on this YouTube, and I thank you very much for listening what I just wanted to convey to you all people. Thank you.
Jorby, thank you very much. Jorby.
So I have to stop the sharing?
Yeah, you stop the sharing, no issue. Keep it like this, keep it like this. Only thing is that there are few questions in between you answer. Till that time I am making that video on so that everybody can see it, video of live. I have downloaded from the YouTube directly, I am showing. Now the question has been asked by our interfaculty questions are there. Dr. Ashish is asking, Dr. Rahul, and Dr. I think somebody else is also asking.
Yeah.
Dr. Shiva.
Dr. Shiva. Then let us start with Dr. Rahul. He has raised finger first, I think.
Yeah.
Fastest finger first.
So very good presentation by Dr.
Yeah, you're audible.
Yeah, both the speakers, very good cases, very good presentation. But I have got few queries in my mind. So in Dr. Jawahar cases, he has shown the ender's nail putting from the medial and lateral condyle as well. This is my first question. So what are the indications for putting the nails from both the sides? Another is the Dr. Jigar has shown most of the cases he was putting the 4 nails. But in most of the cases with Dr. Jawahar, either 2 or 3 nails are there with the screws. So what is the different indication of putting the 4 nails or 2 nails plus screws? And Dr. Jigar was telling, third question is for the tip apex distance must be not more than 1 centimeter. But Dr. Jawahar has not commented on this, and as I have seen most of the x-rays, the nails are far apart from the tip. of the head of the femur.
So now let me give answer.
Yeah.
Listen very carefully. My cases are with 2cc screw, and it is very easy to push cc screw at the subchondral level. Maybe sometimes difficult to put the nails at subchondral level. If you can put at the subchondral level, it is okay. But if you cannot put, these 2cc screw makes a wonder. There is a big difference when you put these two screws, because you have somewhere some intake lateral wall. Secondly, as far as the lateral nails are concerned, we want dynamic valgus force. We want something like C. We want something which starts from below, from the lateral cortex, lateral condyle, and it goes to the trochanteric tip, and it every time wants to have a valgus at the flexure side. So the maximum valgus force you are going to get when you pass it from the lateral side. This is what I have experienced. So basically,
but sir, I want, sorry to interrupt in between, but I want the comments of Dr. Jigar on these things, because you are doing this.
Yes.
No, let me complete it. The second part, I think you have asked for the medial and lateral entry. Then you have asked for the
tip and apex distance.
Tip apex. That is what I said, right? Yeah. Now there are cases where when you want to go for a forget lateral wall fixation, you need to go as subchondral as possible. This is a possibility, but the problem with this, that many times it is difficult, which you go through my video, and I have explained it why the length of the nail is so difficult to measure. There are n number of factors which are occurring. So it's at length, it is on the YouTube video, what exactly works and how you decide. But yes, it is not like you avoid it. If you can put subchondral, good. Yes.
Thank you. So Dr. Jigar, do you want to?
Sir, can I speak now, sir?
Yeah, you can speak it. No problem.
Sir,
your video is ready for the audience. Let me tell one thing for the audience. Now video is ready. We have downloaded from it is directly, you can see from the YouTube itself. So video will run, and for the audience, I am getting so many questions. Please stay on. After this video, we'll take your questions, and then we will go to the complex cases. For audience, we have to announce like this. That's why I'm announcing. Okay, Jigar, you can go ahead.
I put yes. Sir, Rahul, I put four enders nail of 4.5 millimeter diameter in almost all cases, more than 80 to 90% of the cases. For tip apex distance, what I have said is keep the tip apex distance less than 1 centimeter for minimum 3 nails. So that gives good subchondral hold. Okay?
Yes.
Okay.
So when Jethwa sir is telling.
Yes. Go ahead. Then I will ask the question. Somebody has asked the question regarding these only.
What Jethwa sir is telling, Jethwa sir is using 2 or 3 nails, and then he used CC screw. What I have felt is so many times it is very difficult to detect the position of the lateral wall, and there may be some hairline fractures running in the greater trochanter. So while pushing the CC screw, you may get separated the greater trochanter, which is already having an undisplaced fracture. So that's why, if possible, keep 4 nails right from below to above, and that gives absolute stability, and you don't need to the CC screw. That's what I feel. But in some cases where I feel that I need to fix the greater trochanter, I use a separate CC screw for that. If the fracture is absolute busy cervical, where there is minimum possibility, and when I'm sure that there is no breach in the lateral wall, then I try CC screw from the lateral wall, and that gives additional stability. So overall, what is concerned.
Hello. We have lost your voice.
So
internet connection.
I just say that
Jawarbi, there is a difference of opinion between two. One is saying that
no. There is a different type of methodology.
Yeah.
Don't go with this message. Yeah. I say that we have learned in any fracture there should be interfragmentary fixation, and there should be neutralization implant.
Right.
So what you do is interfragmentary fixation by these 2 screws, and the neutralization done by the ender nails.
Okay.
So
but for lateral screw, you require lateral wall, huh?
Yes. So in my video,
that cannot be a forget lateral wall fixation.
No, yes. There are 2 types of things. That is what I said. When you have something where there is a no possibility of having any lateral wall, if you have, yes, you should use it. If you do not have, in those cases, you can pass only the medial nails. Now, there are two things which I have explained in my video on YouTube. Each and every part has been discussed, but what is very important is I sometimes not able to pass four nails in the head, but because I keep the nails outside at the lower end, four nails outside in the medial side sometimes gives trouble. But it is not that when there is a complete lateral wall shattering, I pass four nails. There is no, otherwise also in a subtrochanteric, we pass four nails, two from the lateral side, two from the medial side. Now, there is no pinpoint principle. This is a very smart technique. It's not like this. You have to go with each and every case. Go on doing in a simple case, two-part fractures. Just do not keep it for complex fractures. And gradually you will know all tips and all sort of experience. Yes.
Navin
So,
bhai,
yes, sir. Yes,
I
sir.
I want to make a comment here.
Okay.
See, unfortunately, when Germany started doing endless nail, because that is where from the nails have come,
Okay.
they were just putting nails, and
Austria,
most
Austria, Austria. From Austria, it has started.
Yes.
yeah. So that is where the ender started, and where I've gone through the previous papers, the earlier papers, and everybody was putting the way just the nails went, and that is why great problems happened, and the implant was forgotten. Gradually, surgeons from Gujarat and Ahmedabad have understood each and every problem, complications which have occurred, and that's why the solutions have come up. Whatever the last solution given by Jawahar about this turbo screw, he may call them turbo or any name, that's a different issue. Probably he's thinking about occupying the neck with more implant works. Only issue is that because here there is a wide area available for the fracture to heal, even though you put this 5 implants inside the neck, it doesn't affect the union. That's a good thing. And fortunately for him, he is required and the screws have helped him. For example, I have not used these screws. 2 cases only I have put the screw. I have just put the screw. Probably they have done nothing. And I don't think Jigar is putting screw.
Yeah, I also don't put screws in most of the cases.
Okay.
Okay,
Okay, the probably what the Jawad Jetwa is telling is by turbo screw is he is using the screw to fan the nail and expand the and put that ender's nail under the tension. In between two ender's nail, he is putting the turbo screw. I think so.
Yes.
Navin,
Is it so, sir?
Navin, I also want to add. Navin.
Yeah, yeah, add it, sir.
Yes. So what Dr. Jawahar Jetwa is doing is extending the ender's nail, which is short, by putting a turbo screw, by putting that screw subchondrally. Since the screw is touching the tip of the ender's nail, you can call it as extension of the ender's nail itself into the subchondral bone. Though it works to compress the lateral wall if there is a fracture, but otherwise this turbo screw is getting fixation in the subchondral bone, that is doing one. And second thing is displacing a bent wire by putting screw in between two wires, that also compresses the bone on either side, so impaction it happens. Probably
Now,
that's what.
yes. Now, very important part is again, you cannot compress or collapse the fracture. So what you do is you pass this screw, and I have very specifically said 7 mm, not 6.5, because understand you need a thick drill tip pin. You don't want that 2.3 guide pin. The 2.3 guide pin goes anywhere. And I have also explained in my video on YouTube that what is the workup? Workup is you have to have 3D CT scan. You know where is the intake lateral wall. So something which is very important is that you try to collapse and compress the fracture with the screw wherever it is possible, so that you know it is on table day one, there is a good apposition of the fractures, and then you enhance it with the enders. Yes, sir.
So you do 3D CT for every fracture?
Yes, whenever, unless patient is very poor, because that is the way I learn. If I have not done that, I would not have learned where exactly I am able to pass the screw. Because
You
that is something.
did not show any CT
Oh,
view.
I have shown you. I'll just go back and the recording and you'll see that. And in my this thing, because I wanted to see only 2 slides, case paper presentation, I'm not gone with the multiple slides. But I
You were
do.
speaking about some special metal being used for this nail.
Yes, yes. There are 2 parts which are very special. One is 7 mm. Again, yesterday's and day before yesterday's, so many discussions were done for the parallel screw. You are not able to pass the screw where you want because you are using a bendable, pliable 2.3 guide pin. So if you use 7 mm screw, that is the one thing. And secondly, the alloy. Alloy is I'm using from Ormat. It has to have elasticity. I have used other companies, and some of the colleagues we are working with me, they also have used other company, and now immediately they come out that this is what is the difference we can feel now. So there is a big amount of metallurgy. And let me tell you, we have so many discussions about the imported implant. People are always, praising about the imported implant, although same implants we have done or we have manufactured in India. So what is the difference? Difference is in the metal. You can't see what is the AO metal. AO metal is AO metal. AO metal is not 316 LM. Zimmer metal is not 316 LM. It is called Zimmer metal. That is the only secret they have. And that is the reason why their implants works wonderfully.
Absolutely right. When we studied this for the flexible nails, we studied that flexibility is different with the different nails.
Yes.
And so we developed the flexible nails which are much more flexible than the enders. So this metallurgy also differs
It's
with
a
the
big
companies.
thing. That is why imported implants will always be in a first row, because what is the secret is their metal.
Can I add one more thing here?
Yes, sir.
I don't know whether any one of you has used Lafitte nail. Lafitte nail.
I'm hearing the name for the first time. I am hearing for the first time.
Okay, then I'll show you the diagram. I used to use the Lafitte nail because the nails were coming out. The Lafitte nails are designed in such a way that the 3 inches of the distal part of the nail is serrated and things get locked. So it doesn't come out. These are the Lafitte nail which I used long back, some 20 years back. Now, of course, I am not using Lafitte nail. They are not available in India.
Advantage had made it. Yes, sir.
I was the only person probably who used it.
Yes.
And Lalit was the only one who imported them.
Yes, advantage.
Gawar bhai, can I ask you a question?
Yes. Mandora sir, please.
So, if the lateral screws are not compression screws, may I suggest that they should be fully threaded?
They are compression. Who says
they are compression screws?
Yes.
So
he said that it is an interfragmentary compression and the nails are the neutralizing plate inside intramedullary neutralizing plate.
So then you first put the screws and then put the nails?
No, not necessary. That is the reason why. Again, my appeal is go through my video. Everything, it is a 27 or 30 minutes video. What you need to do is sometimes, as Jigar has said, that the bent nail helps you to get reduction. In those cases, you put a bent nail first. Try to get the best reduction because you are getting. And then with one nail also, you are able to get the compression with a CC screw. But if you pass 3 nails and then you try to pass with a screw, you are not going to get compression. So at maximum 1 or maximum 2, that is the only area. Otherwise, sometimes what I do is I put this drill tip pin inside. I push one particular screw, and then if I feel like it is coming on the way, then I keep the drill tip pin inside. I just withdraw the screw, I let the nail pass, and again I fix it up. But the hold which you feel it is so good, and there are certain sort of, the feeling when you are rotating it, when you are displacing the tip inside. And then you know that, yes, you are. So that is why the interfragmentary screw is first, while turbo screw is not interfragmentary. Turbo screw is just to have better hold in the head.
Yes. So can I add something?
Yes.
Can I add something?
Yes, sir.
So what I feel is ender nails are unlocked nails, and we pass the nails from the distal fragment into the proximal fragment. So now there is a complete tube of bone over the nails. And as these are unlocked nails, they provide collapse over these nails, so that after 2 or 3 nails, we can just release the traction and most of the things will get collapsed. So then we don't need much of the collapse. and we don't need any compression screw as well. So these are just two different philosophies only. And where I am using 4 nails and collapse everything on table, and Jethwa Sahib is using 2 or 3 nails with 1 or 2 screws. So that ultimately it should be a very good stable construct.
Yes.
That's what the idea is.
Yes.
Can I speak?
Okay. Okay.
Yes, sir.
Now,
Dr. Jamin was wanted to say something.
yeah.
From
Yeah.
Delhi.
My question is for Dr. Jawahar. Sir, you are doing that posterior band and you are not inserting the nail intraosseous. Your nail is just in the subcutaneous plane.
I mean,
Now
touching the bone.
Touching the bone. So the one reason that you mentioned for posterior band is so that the irritation shall not happen. Another reason that you mentioned is to prevent external rotation deformity. Now my question is, how is this posterior band going to help in external rotation deformity?
Yes. Again, go back to my particular that slide, which I have analogy given with a railway track clamp.
Right.
So something is posteriorly bent outside the femur distally.
All
Something
right.
is anteriorly bent inside of the proximal tip.
Okay.
And visualize that hook. Now, if you want to go for external rotation, both the tip will abut.
Okay.
This is again, correction is that it is not for the irritation of skin. It is for the irritation of the synovium and the knee joint itself.
All right.
Nails are touching the inside of the touching the cortex of the bone.
So the mechanism is actually abutting of the nail on the medial cortex that is preventing the external rotation.
Yes, and
On the
secondly,
lateral wall. On the lateral wall.
Medial wall.
Yeah,
medial wall. Sorry, middle wall.
What very important thing has come up is the whole thing from 90 to 2000 was a problem of external rotation deformity and the backing out. So now with these 2 screws which are interfragmentary, where is the question of rotation? Because you have passed the interfragmentary in the best of the rotation. So there is no problem with the rotation once you pass these 2 screws.
So Jawarbi, there is also a question that in some of your cases, you use the K-wire as a pin for preventing the external rotation, or a 3.5 screw in the distal hole eye of the ender's nail.
Yes.
Does it help? What is your experiment?
Yes,
what
it helps.
What is that your experiment?
Now what happens that when you pass such nails, in a particularly very old and osteoporotic lady with a short stretcher, you
have you shown that case? Have you shown that case or something?
No, I have not shown this case where the anterior cortex at the distal it completely is broken. Now in those cases we know that we want to keep the nails outside and the anterior window is broken. Then there are all chances that when the nail slides, it will slide so back. And the ideal situation is not everywhere you are given 90%, 95% you are given ideal situation, but in some of the cases, the anesthetist will say, hurry up, hurry up. In those cases, it is better to put a small pin, which is again, specifically 1.8 mm pre-sterilized Ormed K wire, not anything else. Make a U-pin out of that, and that U-pin only can fix the nail so well that it will reduce the chances of baking out. Almost I say there were 10 baking outs, then only one is baking out.
Do you have any photograph or X-ray with you in the computer?
Just to open it up and then I'll show you.
You open up. You be ready till that time we are running. Oh, okay, you saw it. Then we'll run the video again.
Okay,
Dr. Jawahar sir, one more thing. When you have fixed the proximal fragment so well, you have practically covered around half of the neck area, half of the head area. Then why do you need that posterior band for prevention of external rotation? The implant itself is so well fixed that there shall not be any external rotation. Number one. Number two, if posterior band is there for the external rotation, then by what mechanism Dr. Jigar has been able to prevent his external rotation? I think external rotation is more about the fixation of the implant in the osteoporotic bone rather than because of the posterior band or anything else.
Okay, now let me, Jigar also will give some answer, but let me just give you a reply. Number one, we know the medial condyle. Medial condyle is posteriorly bent. So if you put something which is straight, is going to irritate the knee joint. So posterior band, otherwise also, even if Jigar is putting inside of the medulla, I mean inside of the cortex,
All right.
he gives a posterior band. That is very, very important. And what was the second argument you gave?
He said that there is a
when
good
there is good fixation, we have covered, as per your slide, we have covered around 54% of the neck region by these 2 screws and 3 Ender's nail. Then why do we need something else to prevent the external rotation? This step, as we are doing PFN, so we do not need anything else to prevent external rotation. It's the stability of the implant.
We don't do. Yes, we do not do anything. Some of the cases where probably jiggers or somewhere we put a derotation plaster. Otherwise, nothing is given. Once you have put 2 screws, there is no need for. And this whole idea is so much documented in the literature that people don't think of. Now, as I've given you the answer that once you put a 2 interfragmentary 2 screws, where is the question of external rotation?
Right, absolutely right.
Can I add? Ashish bhai, can I add now?
Yes, definitely.
So then Kanabar sir wants to say something, or anybody has any question, please raise your hand.
While Jethwa sir is putting the nail on the medial cortex and he is telling that that is preventing external rotation, I am pushing my nails inside the medial cortex. So still the nail is antiverted at the tip at the upper end, and a posterior band is given at the lower end. So it becomes a hook-like structure. And with that, there are 4 nails inside the medullary canal.
All right.
So that itself becomes a quite stable and reasonably rigid structure over which
to prevent external rotation.
Yes, over which it is very difficult for the distal fragment to rotate externally.
Absolutely right.
So jamming and fanning, all these things collectively help.
Jigar bhai,
it is not only.
Jigar bhai, on collapse of the nail, probably that abuts in the medial cortex lower down, and that gets the extra point of fixation. But when the force is large, many times you must be feeling that they are coming out of that area.
Navin.
Okay. Now one more question.
Navin.
Yeah. Who is asking?
Navin, Shiva.
Yeah. Shiva, yes, please.
Yes. See, what Dr. Jethwa is telling is the lateral wire. If a bend is given, when the femur rotates externally, it blocks what is said about the railway.
Railway hook. Railway track hook,
but if it is on the inside, when the external rotation happens, it comes out medially and becomes more prominent.
No, sir. You have still not understood. Again, go with my video. Okay. Again, understand. It is a hook inside.
Can you
and for this reason only, we had this hands-on workshop in our all workshops. The hands-on was only to understand is how these 2 bands prevents external rotation.
Sir, Jawar bhai, can you show that video? That part of the video only we'll see from you.
Jawar sir, one more thing. In your video, you have specifically focused on patient doing active internal rotation on day 1.
Yes.
Now, this is something that we do not ask our patient to do because we don't need internal rotation in day-to-day activities. Is there any specific reason that you ask your patient to do active internal rotation on day 1?
Very good question. Whatever the implant you do, if patient is able to do internal rotation on the second day, your fixation is dependable. This is the test. This is the way any of the implant. And this is where it's a maximal display destabilizing forces when you do internal rotation.
All right.
Can I speak here now?
Yes, sir.
Yes, sir. Your inputs, please, sir.
Yeah, about the compression screw. Somebody had mentioned that once you have given a compression screw fixation, then the nails will work as buttressing. Nothing more than that they are doing them. So that is one thing. Secondly, about the external rotation. See, naturally, everybody keeps the leg externally rotated because that is the most comfortable position the person will have. Even a painful hip, person keeps the hip in the external rotation. So day long, the person keeps the foot in external rotation while resting. So that is why, to prevent that external rotation, if our jigger is putting that plaster board, but believe me, in last 30 years, I have never given a single patient any plaster board. My patient is up and above next day, and I allow the patient to take as much weight he or she wants to put. In an elderly patient, the most important part is you make them mobile. If 3 weeks we are going to give a derotation board, we are going to increase the chances of deep vein thrombosis.
Yeah, I agree, sir.
Of the knee, many
Sir,
complications are likely to get.
yeah, sir. Let me add, sir. Sir, because when I started doing Ender's nailing, the big question was on external rotation deformity and inadequate rotational stability of the fixation. So that's why, because of that scariness, I started to put my patients on derotation boot. And I am not using at all that plaster derotation boot. We just use that derotation brace, which is absolutely removable, and patient removes it twice a day. So that and we have, over a period of time, we have reduced that time. Previously we were keeping it for around 2 weeks. Now we are reducing it to about a week. And in those patients in which we feel that these patients are absolutely morbid in terms of keeping in the bed, we just make them sitting by the side of the bed, and in a short while, with just 4 to 5 days, we make them stand as well. So now we are working on that as well. So I also feel that with that kind of absolute stable fixation, we may make the patient stand, but I am in the process still of doing it.
Yes, that is why let me just complete. It is a sea change when you put 2 screws, because patient is able to do active internal rotation. So there is no possibility of external rotation deformity. And this is
sir.
And secondly, very important, don't forget that this assembly is allowing micro motion. All you do, still you allow micro motion because of the metallurgy of those nails. Yes.
Jetwa sir,
The
yes.
flexibility,
when we are doing DHS or PFN, we see that when we give compression, even after giving full amount of compression in postoperative period, fracture collapses. So when we put this 7 mm CC screw, fracture is still going to collapse.
No.
Once it collapses, so what is the role of that screw in laterally?
I tell you. You are very true that collapse is going to happen. But there is a big difference. You are not able to put your DHS or PFN screw right angle to the fracture surface, because you have a limited area from where you can introduce. Here, CC screw you can put from anywhere. That is the first thing. Second thing is, yes, proximal femur, the whole world has just put off their weapons. Whole world is saying, okay, if there is a collapse, let there be collapse, otherwise there won't be a union. So how can you go for a minimal collapse? That is what you have to do. That is why all are sliding implants. Sliding implant is always good.
I have one view about the compression and collapse. Basic. Whenever you can compress any fracture, there is no place for collapse. If the fracture is compressible, there is no place for collapse. And collapse and compression cannot coexist. In this unstable fracture, there is always a void even after your screw fixation in any implant.
Absolutely.
So collapse and compression cannot coexist. It's a myth.
No,
compression, you are not getting compression with that CC screw. You are getting a fixation. Still, there will be a void in elderly patient with the small fragments. So collapse is inevitable. Collapse has to be allowed. The problem is how to get a controlled unidirectional collapse in the neck shaft axis. That is the problem area.
Now go back to the physiology. We know that the cells which are exactly at the fracture surfaces, they die. When they die, they create a gap. And when that gap is there, it's going to collapse. And that is more so in a transcervical.
So the compression and collapse cannot exist. If somebody says that I have compressed the intertrochanteric fracture unstable, that is a myth. Because when there is a gap, collapse, you are reducing the gap, but you cannot compress two fragments. Compression is totally a different thing.
Okay, now
can ask anybody wants to add anything?
Not addition. I just want to ask one thing to Dr. Jigar.
Yes, please.
Yeah, Dr. Jigar, you have shown a very good technique of correction of posterior sagging with the help of Ender's nail.
Yes.
All right. Now, do you have any tricks to correct the varus or the flexion of the proximal fragment that happens in high subtrochanterics? Now the problem. Now my issue is I am doing PFN. I am doing DHS. These two implants are very good. They take care of majority of the proximal femoral fractures, except for the high subtrochanterics, where despite reduction, the nail is not able to maintain the flexion and varus of the proximal fragments. So I understand that Enders would be able to maintain that reduction, but is there any way so that we can closely reduce the flexion as well as the varus deformity?
enders will help you in correcting that flexion of the proximal fragment.
Okay,
See,
do you
when
have any slide or video for that so that we can understand it, how to correct varus and how to correct flexion?
The slide in which I have shown that the distal fragment was sagged down and the proximal fragment was little anterior. So
Right.
in case of flexion, it will be more angulated anteriorly. Okay, so you have to enter with whatever the gap is left, you just have the tip quite bent anteriorly, so that the nail will go from distal fragment to proximal fragment with an antiversion, with much antiversion at the tip, that will enter into the proximal fragment.
And we will be able to reduce
yes,
it.
once
Okay.
it goes around a centimeter, then you rotate internally almost 90 degree, more than 90 degree. That will bring your proximal fragment down towards with the alignment of the shaft.
And what
so
about
that
varus?
will correct your flexion.
And what for varus?
For varus, most of the varus, what I have seen is that gets corrected with traction.
Traction.
Okay.
And if it is not there,
the things which is left with even after traction, that you can go more medially, and then you can turn around at 180 degree. That will bring your proximal fragment also laterally, and that will add on to the valgus. And at the same time, even if it is there, you can use a sand spin or an ST pin to correct it.
So you have to use the reduction tool if it is required, or you may have to
go.
But you may have to go for an open reduction.
Open reduction
you have shown one case of open reduction.
Open
also,
reduction, yes. One should not hesitate. But what I have almost most of the time not at all needed any tool for this. I have been able to reduce with enders only, and whenever in doubt, I never hesitate to open. But my opening ratio is hardly 5%.
Okay.
So now let me just do that.
Can we now start the? Can we start the video?
Last question, Navin sir.
Yes.
Question.
Who is asking?
Dr. Jigar, I just want. Yeah, Dr. Jigar, can you hear me?
Yes,
Dr.
please.
Jigar. Yeah.
Yes, sir.
So my first question again, I am repeating. What is your comment on a particular ender's nail from the lateral side towards the shorter nail, GT, to prevent the varus collapse? What is your comment on this?
I use the lateral nail only when there is lateral wall breach. See, there is a bending force which is applied on the proximal fragment when there is axial loading. So that lateral nail will give that dynamic valgus force, and that will prevent that bending force. That will counteract that bending force. So the lateral nail from lateral entry is needed only in cases where there is a lateral wall breach. That lateral wall breach means either a GT fracture or the fracture in the lower shaft also, lower than the graded trochanter.
So in how many % of cases you are using this lateral? Because
hardly 10 to 15% cases. Even with lateral wall breach, if I get absolute stable reduction with my 4 medial nails, so many times I don't put, because it is very difficult. It's not that easy, because it can come out anywhere. We don't have much idea about the lateral wall fracture and lateral wall breaches. When you feel on IITV that it is absolutely in, but on postoperative X-ray, you may see that your nail is coming out quite proximally lower down.
Yes,
so it is better.
That's why I'm asking.
Yes.
Okay. Can we go for the video, Jigar bhai?
Sure.
Yes.
Sure.
Navin sir.
I'm starting the video.
Sir, Navin bhai, I have already sent my pen drive to you. If you can run from that pen drive, then it would be excellent.
Oh, you want me to run
So
from the pen
now
drive?
what I can do?
That's wonderful, sir. That webinar ender video.
Okay, let me check.
I think yes.
No name.
Because you probably have edited fully.
Yeah.
Yes, I got the point. Yes.
No, I'll check. No name.
Now lateral nail is essentially for
that webinar edited video, sir. This one.
Okay, I will run.
Lateral nail is for subtrochanteric, agree.
Yes, it is not that
it is not for the subtrochanteric.
For the intertrochanteric. So no
PPT,
misunderstanding.
PPT,
yes.
It is PPT file.
Yeah, it is PPT.
Okay, fine. It is opening up.
Chitra sir, you do one table collapse after fixation?
Sorry?
You do one table collapse after
Yes.
fixation of implant?
That is the basics of everything. There are so many tricks which I have given in my video, how to reduce it. Reduction has nothing to do with ender nail or CC screw. Reduction is reduction. all methodology, all sort of tricks and tricks. Even if you have to open up, do everything, because for that it is not like. But there are some of the cases where this bent tip will allow you a good reduction without opening. So that is the way it helps.
It is in the last slide.
No.
Where is the video?
Just start it, sir. I will tell you next.
Second video.
No, but
Second
I
slide.
will start this slide only.
There is a video on the second slide.
Video is in the second slide.
Okay, fine. Okay, your written video.
Just make it full screen.
Okay, done it.
Just click it once. Yeah, and now start it. It will be full screen.
No, I don't think that.
It's not running, sir.
It's not running.
But it is also in the folder. You can directly start from the folder.
Folder? It is there in the folder?
Yes.
No, it's not there.
Video
in the
file.
folder.
You must not have linked with the folder.
No. Then
Only pen drive, it is not going to work.
He has not copied a video.
Yeah.
Okay, no problem. You're not copied in the pen drive there. Let me
so-
run from the YouTube itself. It will work.
Sir, if you can copy this and can you take it out, then it will be better if it is possible.
Then I copy the slide and put in a new presentation. That's
Yes.
single slide.
No.
it requires a file.
Yeah.
It requires a file. If he is embedded, it is not an issue. But if he is not embedded, it is an issue.
No, this is not going to run.
Meanwhile, can we start a question answer from audience or anything?
Or
We can start from the YouTube, no problem. Sir.
Yeah, YouTube I am starting. I already put that where you had
Fine.
stopped. Okay.
Fine, sir. So
You go ahead.
So
this is the instrument set.
This is the instrument set. Contains 4 nails, each of 4.5 millimeter diameter.
Make full
Make it
screen.
full.
YouTube video full screen.
Full screen will resolution is low. He has loaded because the resolution
Fine,
here.
no problem. No
Resolution is only 240p.
Okay.
That is the issue.
So,
Yeah,
so I think we should be happy with this. We have to be happy with this.
I can make it full screen. No issue.
Yeah.
Okay.
Is it fine? Is it
Yes.
Yes,
Okay,
yes.
fine.
Go on,
Reasonable.
Okay.
Okay,
Yes,
so
sir.
I have already explained this slide that we need to keep in mind about the rotation of the nail, anteromedial and posteromedial direction.
Yes,
And this is the male
patient.
71 years. This is the preoperative X-ray, AP view, and this is the lateral view. It is not much displaced. So now I am taking the entry from the upper pole of
Here
the
you
patella.
take entry directly from hole.
Yeah, I put a 1 centimeter incision only. So many times I don't put even incision.
He's fond of stitchless surgery.
It is hardly 1 to 1.5 centimeters incision. So that the entry hole is sufficiently widened so that we can put 4 nails. This is the final entry. An artery forceps is kept there. Now I will take the size of the nail from superior pole of the patella right up to the subchondral area. This is the lower end of the nail, and this is the upper end. So now we'll start the bending. We'll give a posterior bend around 3 centimeters from the eye.
Yes, clear
Then
this question because so many people have asked from where to bend
So stop
and
it.
how much to bend. So I'm stopping
it.
here. Yeah.
Yeah. So one more thing important is when you do a right side surgery and left side surgery, the bending will change. Okay. So just keep in mind that every time it is not like that you pull it towards you. It gets changed. Okay.
Yeah.
So sometimes people will think that every time I have to pull it in towards me. And they
Either
give
you have to change your side also.
Yeah, so just keep in mind and after giving the bend, put the nail over the femur so that you can come to know that you have given posterior bend at lower side and anterior bend at the upper end. So the posterior bend is given around 3 centimeter from the eye, and the anteversion bend is given at around 1.5 to 2 centimeter from the tip. So that will help in the reduction as well, and that will become a hook. So now again you can see I have bent the nail from the shaft of the nail, the
Medial
shoulder,
bend.
medial bend. This is the medial bend to put the nail on the calcar. Now I am pushing my nail inside. The assistant is giving constant counter pressure. The nail is pushed right up to the fracture site. Checked in the other view, in lateral view, that's fine. So now I will push it further. It's pushed right up and will again check under IRTV. And now the rotator is changed to terminal impactor. See, the position is good on AP view. It is going well on Calcar. So we'll push it further, right up to the subchondral area. So this is the final view on lateral side, and this is the view on distal femur. Another nail is taken.
So
same bend is given.
You initially put this inside only, directly. Or you put all the nails together inside, one by one?
No, one by one only. No, one by one only. Huh?
No, I know one by one, but you had
Please
pushed
stop it.
Stop
the video. Stop the video,
you have pushed it inside totally,
Sir,
the first nail.
Yeah, I pushed the first nail absolutely inside. And by that first nail, I decide my length of the nail again.
Okay, now the question
Yes,
has come. How do you decide pre-op what size of the nail you will start to? And then you will bend. Then you will bend accordingly. Yeah.
Yes, sir. So first I take the nail from the whole set. I put my nail exactly over the femur from superior pole of patella right up to the subchondral bone, and that is my actual length. But that may vary 1 or 2 centimeter plus minus. So the first nail I usually take off one size short. So what happens is, if my nail is short, if I got a bit difficulty in reduction, then I'll not take that nail back, but I'll push that nail little bit more inside, so that the next nail I can take off one size more. It is wiser to take one size shorter initially. The first nail can be of one size shorter rather than a long nail. Okay, because a long nail will impinge lower down, and you can't get it out, left it out.
So audience got the answer about this.
There is only one.
Sir, can you go back a little bit? Can you go back a little bit, sir?
Jawar, do you want to add anything in measuring? Yeah.
Yes,
give
I
your
just
input.
say that.
Or any faculty wants to say about how to.
Navin bhai, just a minute.
One by. Please.
Can you take the video 10 seconds back? 10 seconds back.
Okay, no issue. I will take it, but let the others view. We know other faculties view.
I had one experience.
Okay, Kuntal bhai, you start. Then Kanabar sir wants to add something, and Dr. Jawad Jethwa wants to add something.
What Jigar bhai is showing, inserting nail in the first nail in the intramedullary canal. I had one bad experience by doing this. When I inserting second nail, if I want to extract that second nail, the first nail also go distally and going in the medial femoral condyle, and I losing the control over that first nail. So I prefer that first nail should remain somewhat outside, so we can have control on that first nail. So
if it is to be removed, it can be removed easily, right?
Yes, that's good.
Or it will go inside the condyle and losing reduction.
Okay, now I just want to say, in my YouTube video, there are 3 classical ways by which you can measure the undernail size, which I've explained very well. Please go through that.
Okay.
There are pinpoint anatomical points from where you can decide this.
Okay,
yes.
Kanavar sir.
Only one small addition. The measurement, if you take from tip of olecranon to the tip of little finger, keeping the hand straight, that is the distance which normally you require of the nail.
Yes, it's a good tip. Yes.
That is required normally.
Yes.
Yeah, sir. What my point is,
from tip of the elbow, the olecranon.
Yeah. In residency, sir, we were following that. So
okay,
Doctor. Please pause it.
Yeah, Dr. Jigar. Now you say you have given a 10 degrees antiversion to the first nail. Yes. How much antiversion you will go to the second nail? Same amount, less or more?
That is very, very important. See, once I have got good anatomical reduction, then I will reduce all these things. So for minimum 2 nails, I will give both antiversion curve, a medial curve, and posterior curve. Posterior band is given in almost all the nails, but medial band I do it variably. Once I have got it good alignment, I'll reduce my medial curve so that I can have my nails more laterally. This video only is showing the same thing, that we will see in just next 5 minutes.
Okay, what about the anti version? Do you reduce the anti version in sequential nails?
Yes, once I have my nails more in the anterior half, in the next nails, when I want it to be more in the center or in the posterior half, I'll not give an anti-version band.
All right.
So now this is the second nail. Just 5 seconds back, sir. 5 seconds back, please. Little bit more back, sir. I just want to show the position of the bent nail.
Okay. Just still back.
Still back. Just 4 minutes 10. Yes. Yes. Just play and then make a pause when I'm showing 2 nails. Yes. Pause it, sir. So extremely sorry for my poor net connection, so that I could not.
No issue. Yes, these
are
the 2 nails.
So here, when you see the original company given nails, it is quite straight, and the nail which we have bent, it is quite curved. So this is the difference between the 2 nails, the company nail and what we do after bending. So when we are pushing these nails, well, the nails get straightened out, it will give 3-point fixation as well. So that correction of the curve itself is giving strength to the stability. So now I have pushed the second nail right up to the flexure site. And now I want it a bit lateral to the previous nail. So sorry, this is a bit second nail. It is going right on the calcar. And as it was touching the medial cortex, I have rotated it little bit externally.
It was in the center.
Yes, it was in the center in lateral view. So now we have pushed the second nail as well. This is the AP view. It is going right on the calcar and right up to the subchondral area. This is the same size nail by length. So now this is the picture after 2 nails. The third nail, again, the posterior band is given. See, I have my nails in the center part of the lateral view. So still I will give the anti-version band. And the medial band will be less now. So when, if it is difficult for me to push my nails inside, then I take the help of the owl. And with the owl, I push my nails just a bit inside so that I can get some space to push the next nail. So push right. Now I want it little lateral. So I have rotated it externally so that the nail has to go lateral to the previous 2 nails.
To get the fanning.
Yes, to get good fanning and to have good catch hold of the proximal fragment of head part. I'll check in the lateral view. So it is going much anterior, but still it is negotiating in the neck. So now I have pushed it inside the neck and it is going in the anterior half of the nail. That is good fanning. So now we'll see in the AP view. See, you can see the third nail coming out lateral to the previous 2 nails. So this is good fanning in the lateral view as well. So again, I want my 4th nail to be even lateral to the previous 2 nails if possible. This time when I felt that there is good enough catch hold of the shaft and it is little bit tough to push the nail, I take one size short so that at last when the space is less in the head, it does not make much difficulty in pushing the nail and rotating the nail.
When you loosen the traction at
pause,
what level
pause.
after
Pause,
first
yeah. Question is when you release the traction to get the collapse on table.
See when see in this case, if you see there is hardly some gap. So in such cases there is no need, even somebody can leave the traction as it is.
No, not this case. After inserting of 2 nail or 3 nail or after
3 nails, minimum 3 nails, because with 2 nails I don't feel that it is absolutely stable. Okay. So I push 3 nails and then only I reduce. And if I see some gap only. See now with this 4th nail, it was touching the anterior cortex. So now I have rotated it internally. It is still touching the anterior cortex. So I will still rotate it a bit internally.
To get into the posterior one.
Yeah. Okay. To get it off the anterior cortex. Yeah. I want it in the anterior half only because I have 2 nails centrally. Okay. So now it is, you can see the gap between the anterior cortex and the nail. And now I will carefully change my rotator to terminal impactor so that I don't lose the hold of over my ender. And the counter traction is continuously given by the assistant. And now I will push my nail. See, the nail is coming out lateral to the previous 3 nails.
Yes.
So this is having excellent hold in the proximal femoral fragment.
Jigar, can you do you experience sometime when you inserting nail in the medulla?
This is the just a minute, Kuntal bhai. The video is on. Let me finish it. See, that is the AP view. You can see all 4 nails. I take the invaginated soft tissues out. And I can feel that my all nails are inside the medial cortex and nothing is coming out. There is hardly 1.5 to 2 centimeter incision. Let us see the immediate postoperative X-ray. This is the immediate postoperative X-ray with all 4 nails we can see. So that is a good fanning. 2 nails anterior, 2 nails central. So good fanning in lateral view as well. All 4 nails are inside the medial cortex, but believe me, it is just below the subcutaneous tissue. There is no abutting on the patellofemoral joint as well. Let us see the 5 months postoperative view. The fracture has almost fully united. 100% union is there.
Very good.
And the nails lower down. That's the lateral view. Just a minute, sir. See, this is the incision site. One can hardly mark that this is the incision. He is having full range of motion. He is able to sit cross-legged. Full flexion of the knee. And this is the video, 2-year follow-up. There is no external rotation deformity at all. He is able to sit on the ground absolutely easily. And this is the way he is getting up. So it gives a wonderful result with Ender's nail. Thanks a lot. Thank you. So now we can move to the questions.
Jigar bhai. Hello, Jigar bhai.
Yes, sir. Yes, Kuntal bhai.
Sometime I experienced that by inserting nail in the medulla and by inserting the last 4th nail, some of the 3 of some nail go inside the joint in osteoporotic. Then we are inserting 4th nail. The thrust of that 4th nail causing impaction of that nail inside the joint sometime proximally. So at that time, removing of that nail going inside joint, penetrating joint, it's difficult when we inserting the nail in the medulla distally.
See, what I have felt is once I am keeping the nail inside the medial cortex, there is always a risk that if you need to remove it, then you have to extend your incision a bit, and then you can make a window and you can take the nail out.
So
hello?
My experience to keep,
am I audible?
Yes, you are audible, but somebody has started something different there, so that voice is coming. Now it is okay.
So, and particularly once you penetrate the joint.
Jigar bhai, you have 2 devices there, so your echo is coming somewhere. Your other device is also working.
Mine.
Yes, when you speak. Yes, when you speak only it comes.
So my experience in severely osteoporotic patient, keep the tip somewhat outside the entry point, and at last you thrust the nail. Because if in osteoporotic patient, if the nail penetrate the joint sometime, it's difficult to remove.
So, I agree, but you need to take care that the nail does not penetrate the joint, because once it is penetrating the joint, then you need to take it out. You need to change the entire track, right, 5 centimeter to 10 centimeter proximal to the fracture, and you have to park it in a different location. So that exercise needs to be done once if you get penetration of the nail. But I have usually not encountered such a thing, because once the nail is inside the middle cortex, and when the next nail is medial to the previous nail, most of the time the previous nails does not move with my next nail. That's what I have seen.
I would add one thing.
Once your nail are outside the cortex, then your hammer or your terminal impactor will touch that nail while you are pushing that nail finally. So during that final 2 centimeter or 1 centimeter pushing of the nail, you may transfer some of your force to the previous nail. that might be happening with the people who are keeping the nails outside the cortex. That's what I feel.
Dr. Patil, do you have to say anything? Patil sir. Let me unmute
I
you.
have one case.
Yeah.
I have one case which has been operated 1 year back. There is one nail has gone into the fovea centralis. Just it has pierced the joint, but still patient has not any complaint. Neither there is impingement, nor there is any limitation of squatting or sitting cross-legged. I have sent the video to Jigar Bhai yesterday only.
Yes. Dr. Patil.
Recent X-ray and video of that case yesterday only.
Dr. Patil, am I here audible?
Yes. Now I am audible.
Yeah, you are.
You are audible to me. Whether I am audible to you or not, I don't know.
Dr. Kashyap, Dr. Kashyap wants to say something. He has raised hand. And Dr. Siva. Yes, we are hearing you, sir. Patil sir, we are hearing.
Hello.
Yes, Patil sir, we are hearing you. We are hearing you. It is okay. Line is
only I have sent one case of ender nailing. Fracture has been united. It was just
Dr. Patil, everybody has heard that. So let us move to Dr. Kashyap sir. Kashyap sir was wanting to tell you something.
Okay.
Yeah.
Yes. Regarding the entry of nail, you are taking a very small incision.
Yes.
Is there any chance of that injury to the superior medial geniculate there?
Yeah, sir, I have read so many things when I was in residency as well. My professor, Dr. Manoj Joshi Sahib, also was putting a very large incision. He was coagulating all those vessels and everything. But over a period of time, I have seen Dr. Piyush sir and so many other people, they were not putting the incision at all. So while putting only a 1 centimeter incision, there is not at all any problem regarding medial genicular or anything else I have seen yet now. I have done more than 500 cases till now, but still today there has not been any single problem.
An extension to that question, whether you are able to remove your implants with the same size of incision, or you need to take a bigger incision.
I have to put a bigger incision.
Yeah.
Okay.
Let him complete. Then Jawar bhai, you come.
Okay.
Kashyap bhai, I have to put a bigger incision because for my extractor to have an angle to get into the eye, I need to even enlarge the cortical window as well. While pushing the enders, we need hardly 1 by 1 centimeter window in the cortex. But while taking it out, I need minimum 2 centimeter length of that window so that my extractor can go by the side of that nail and get the hook inside the eye. Then only I can remove it. But
so
that
removal is more bigger
complicated than yes. But still, you will hardly need 15 minutes for that.
Okay.
And it is only the problem with the first nail.
Can we go to the Jawar bhai and Kuntal bhai? Yeah, Kuntal bhai, please. Kuntal bhai, please.
Sir, can we see a few of the failures of enders?
Definitely.
They are there in the line.
They are in the line. To discuss, they are in the line.
Not like this. There is a lot many things in enders. You just don't think that in 2 hours you are going to learn.
And enders requires 2 days.
Yes, it is a big subject. It's more than PFN.
Can I take
one thing which I want to just say, that the medial artery is to be cauterized, which I have shown in my video, because we want to keep the nails outside. When we want to keep the nail inside of that hole, probably it's not going to irritate those arteries. So there you do not need to coagulate. In my cases where I keep the eye outside, it touches those arteries and it can give too much of bleeding. Right, sir?
Okay.
But one thing I would like to add, because believe me, with this much of enders nail being done by me, I am hardly seeing 1 or 2 cases of back out, or I don't remember any patient with a back out, because all my nails, once they get the collapse from the fracture side, they will go below the level of the entry level, so that there is no opening for the nails to get them out. It is very difficult for any ender to come out because there is a closed window where they have been landed after collapse. So that I would request people that you take this message and we can put the nails inside the medial cortex. There is no harm in it.
But probably that is also an issue because whenever we put anything inside, we should have an ease of removing it. So once it goes inside, then probably you need to make a second window which is lower and bigger.
No,
so
you can just extend that window.
Kashyap bhai, this is the hot question every time to the Jigar, and Jigar always answers like this. So we'll let it be here. He has his own method. Our concept is different, that we need to remove whenever you have put something. There should be a one method or window to remove. But he says that I never removed. I have never required to remove it.
No,
what I learned from Jigar bhai is probably he puts a shorter inner nails for that purpose. Is that correct, Jigar bhai?
That allows the collapse and let the back out the nail. It remains within the canal of the femur.
Yeah.
That is his idea.
That is absolutely in the medial femoral condyle only. So that you just put a window of around 1.5 to 2 centimeter and take it out.
Okay.
Yes.
Jigar bhai, I had an experience in one.
Yeah, Kuntal bhai, carry on.
I had an experience in one osteoporotic patient that I put a nail in the medulla, and the nail was so back out that it go inside the knee joint and damage that meniscus also.
Yeah, we also seen
Kuntal bhai, there are so many cases that people have put enders and they have come out quite proximally and quite distally. But those are the things where we need to conglomerate all the principles.
We'll see that complications also. The last comment by Kanabar sir. Then I have to ask the audience. The audience is waiting for the question answer, sir.
My comment I'll not speak because I had a comment we made about this extraction part only. Once I had to remove arthroscopically the nail. A polio patient, fracture sharp femur, somebody had done the enders and I had to remove it arthroscopically.
Okay, sir. Thank you. Now, let me have some comments and some questions from the audience. The question from Dr. Dinesh Kale for Jawar Jetwa is, your YouTube video shows, meanwhile they have seen your YouTube video, Jawar bhai, that shows that you are passing CC screw before the enders. Jawar bhai.
What I said, this is what I said, you need to have a fellowship. You need to be with the expert. It's not like a simple thing you pass on nails. There are n number of issues, n number of factors. You try to see the reduction. Then if you have done a CT scan, you know where to pass CC screw. In those cases, you pass the CC screw first.
Still,
certain cases where don't pass the screw first.
Still, they have not understood the concept. One question to Jetwa sir again. You mentioned about the micro motion due to ender's nail, but micro motion leads to failure. And absolute stability is the answer. What is your say? Micro motion leads to chaos, not to the failure.
Yes, the word is micro.
It is not macro. He has also written micro. It is
No. The point is micro is universally accepted motion.
Yes, you're absolutely right. I agree with you, but the fellow has not written his name. It is an anonymous question. So
whatever. I would just say that micro is not a problem, macro is a problem.
And Kanabar sir, your student, probably, Dr. Jagat Bhatt has written that what the Kanabar sir has mentioned about regarding the length of the nail from tip of olecron to a little finger is a femur nail. It was his paper at Bhavnagar GOA. That is his comment.
Yes.
Congratulations.
Thank you.
We acknowledge, Jagat Bhai, we acknowledge that it was your paper. So we learned out of that paper and Kanabar sir has made it to the public. So he is the source to make it to public. Now, Jetwa sir, there are so many people have asked the vendor's name and contact to get the enders of that Ormed. So that we are skipping that question. They may ask you personally.
Yes.
Is there any post-op protocol difference between the Jigar's method and Jawar Jetwa's method? Protocol of any post-op.
Neville, let me tell you, no protocol is for any fracture fixation. If the fixation is good, early immobilization.
Yes.
Fixation is not good, late.
Make him stand early.
Don't go with all these things. This is a very much too much in our mind. People have put in that what is the way by which you can put a weight bearing. One more thing which is very important, to keep the physiology working, you need ambulation. You don't need weight bearing. But if you do not have ambulation, patient is going to give so many trouble with the other systems. So what is required is that patients should be able to, even non-bed wearing, should be able to walk. So protocol is when you feel, when you have experienced
So
a good fixation.
it is a pain oriented mobilization. It's a pain oriented.
Let me add one thing.
Again, active internal rotation.
So let me add one thing. Hello.
Yes.
Yes.
Navin bhai, am I audible?
Yes.
So it is to be decided after the fixation of the particular fracture, and you have to balance between the morbidity of the patient and stability of the fracture fixation. When you feel that the patient is absolutely much morbid, a 90-year female who we want to make her out of the bed, then we have to take a bit chance also. Okay, so we have to be confident on our fixation, and we can allow the mobility. So ultimately what matters is final result. Patient should be happy with the full clinical motion and full range of motion without any complications, without any deformities. So that should be the message.
Dr. Mohan Mantri has asked that Enders and titanium elastic nail, biomechanically, how they are different and which is better?
Enders are sturdy.
Navin sir, you can answer it. I think.
Yes, I can answer it, but I have to just put the question so that faculty put. I will put the case. I will put the case last.
No. What exactly is the question again?
Question is Enders and titanium elastic nail. What is the difference between them? What about the flexibility?
World of
Huge
difference.
Yeah,
world
huge
of difference.
Huge.
Okay,
Now let me be very clear. Elasticity of the titanium nail is much more than needed.
Yes.
Need is a apt elasticity. So we want some stiffness. So we want something, and there are n number of metallurgical processes by which you can get. And one more thing, the elastic nail of the local company or elastic titanium nail of the local companies are not elastic. Elastic titanium nail or the important companies are much more adequately elastic. So we need adequacy in elasticity, not too much of flexibility. Otherwise, you won't be able to maintain the reduction. Right.
Okay. Now there are so many questions, similar questions. One is from Dr. Nikhil Goradia to Dr. Jetwa. Why 7 mm, not 6.5 mm CC screw? What is the difference?
Very good question. Again, remember, stop using 6.5 in even transcervical or even any other fracture. Why? We know that when we use 2.3 mm guide pin, we are not able to pass exactly where we want to pass because it bends. It bends because of two things. One is that strong bone is there. Second, very important, listen to me carefully. It is the fascial scar. The fascial scar in the neck and the trochanteric region, which will bend that particular guide pin. So what we need is absolute trajectory. So what we need is a stiffer guide pin. So stiffer guide pin is 3.2 mm drill tip pin. That means guide pin is not a guide pin, it is have a drill tip. Now this 3.2 mm drill tip pin is not made up of the simple 304 or 316. It is made up of 605 metal. That 605 is a stiffer one. You will be able to pass exactly where you want to pass. Even in a transcervical fracture, if you want to pass a 2 parallel screw, you will be able to pass 2 parallel only with this guide pin. Now, to have a 3.2 mm guide pin, you need to have a larger screw, because 6.5 will not leave any metal when you want to use a very thick 3.2 mm guide pin. So for that reason only, it is not like 7 mm is increasing the fixation. 7 mm is because to have some metal over that stiff pin, which is 3.2 mm. So that is how I explained very well in my video. Go through each and every word of that video and you will know what is the difference, how it is making the difference.
Now the question about the complication. Dr. Nitin Patil has asked, what is the incidence in your series of entry site fracture in your series and how to prevent it?
Entry site means at the lower end?
At the lower end.
Yes.
Distal femoral fracture.
Till now, I have encountered two cases. One case, there was undisplaced fracture of the supracondylar, which was healed without doing anything conservatively. And another, it was a displaced fracture that we are going to cover in the complications part.
Okay, so what do you think was the reason for these fractures?
Yes.
The reason, see, in the undisplaced fracture, I was trying to put a lateral nail from the lateral side, So when we have same entry at the same level, that can also weaken an osteoporotic bone, and that created a splinter of the lateral cortex, and ultimately it caused a complete supracondylar fracture, but it was undisplaced. So I removed that lateral nail, and ultimately it healed. So it depends on the osteoporosis of the patient. When the assistant has not given enough counter traction while pushing the nail, and sometimes the second nail in second case in which I had complete supracondylar, that was a bit low effect of the spinal anesthesia, and we go ahead doing with local anesthesia. So I would strongly condemn that one should not try and attempt under local anesthesia, because that gives so much force on the bone when there is some counter force from the patient as well.
So now let me tell you, the distal femoral entry may go for fracture. It is not uncommon, it is rare. Now there are three types of different injury which can occur. One is that there could be a wider hole, or there can be a slit going vertically, or there can be a big 1 centimeter broad cortical strip which has come out. Now first of all, remember that exactly the way I have shown, you have to make the hole, because you are passing number of screws. Secondly, it is the site which is very important. Third part is, in a short stretcher fracture patients, don't push all 4.5 mm. 4.5 mm is too much stiff. So the posterior band which you pass after the first nail or second nail, that posterior band is going to directly give thrust to the anterior cortex. So there you have to pass 4 mm screw. And the worst case which I had, where there was a shattering of the this hole. So what is the solution? Solution is that you pass another nail from the juxta-articular region. Now it is a very rare, but at that point of time with a very high morbidity or some high risk patient, that is another way we can do, and we have done in one case. But otherwise, if you know that you are not passing a very rigid thick nails, all the 3 or 4, then anterior cortex or bursting will not happen.
I would add one thing, Navin bhai.
Yeah, you can edit. You can edit.
Yeah, for younger and strong bone, younger and strong bone.
For Dr. Jawahar,
just a minute. Let him complete. Nehil bhai, please let him complete, sir.
Regarding the entry point fracture, whenever we are dealing with younger and strong bone, I do nibble out for proximal portion after I take entry.
Yes.
And
always
number two for Jigar's incision, I do put skin incision.
And that nibbling should be in the vertical fashion, not the transverse fashion. Not the transverse fashion.
Yeah.
Yes, vertical.
Vertical.
To add the final point. Yeah.
So number that will not splinter. That will not avoid splinter.
Yeah.
You may
for
have
younger and strong bones.
You may have a longer entry, but don't make a broader entry.
Yes. Not this way, just this way. And second thing, after skin incision and fascia cutting, I do get entry with artery. I raise the vastus and I can see the nice flare where I want to insert. My incision may be 2 centimeters, but I don't do blindly. So no sleeve issue is there. Vastus remains like this.
Okay. There was a question. There was. Okay, Ashish bhai, you speak then.
So you want to start the entry point at the level of superior pole of patella or proximal to it?
Yes, this is the question. What I do? Let me. What I was doing is I see the genicular artery and cauterize that. That is the point of the entry that was shown to us by Dr. Divetia sir.
That was the perfect. That is the perfect.
That is the perfect. Where you see the genicular vessel, you cauterize that and mark that point. That is your starting point. I think so.
Now again, let me tell you, in my video, very clearly, with all anatomical points I have shown, where is this artery, which are the other structure, where do you cauterize, but the hole has to be at the superior pole of the patella level in the posterior half of the femur.
Yes.
So what exactly I'm telling you, have to see, now you come out with so many finer aspects of this methodology that you have to really learn, and you have to go into detail of each and every part of that video.
Why posterior part? Because the posterior part is a thicker one. Anteriorly, you may perforate the anterior cortex.
It's a stronger one, and if you perforate that anterior cortex, that will hamper the movement of the patellofemoral joint.
Go to that video and you will know multiple things.
Okay. The people have seen it.
About the young people, you create a window by using a drill and then remove 1 centimeter bone, create a window and then start putting your nails, particularly in the young patients.
So I have shown that why do you use nibbler, where do you use a gouge, how do you make that hole, what exactly the hole is seen at the end, everything I have shown in that video. Right.
Okay, now there are two comments only. Two comments, good comments are there. For Dr. Jawar Jetwa, there is a comment that your biomechanical aspect was mind-boggling. Congratulations, sir.
Thank you.
And another the myths about the enders, he has said already that wow, never knew so much to be learned in good for old enders. We always thought that enders, benders, and blunders blunders.
Now let me give me a
Very
comment.
useful.
Enders are wonders. These are wonders of enders.
It is Dr. Sitaram from Guntur. He has said that he has expressed this feeling.
Now, very good important point is that so many times people ask me, my residents and my other co-colleagues, do you do undernailing? I say, no, I'm not doing undernailing. I have stopped doing undernailing. I'm doing something else. And something else is like the old plating and the locking plate. So it is not like the same undernailing. The whole word has changed. Please go through each part and there is a big change.
Yes. So these webinar is for that.
We need to change the name of undernail and that this is some different nails. Then only we will get some popularity.
Jigar's gender nails.
Now question is now question to the faculty is what is the absolute contraindication?
That was my question I was to ask. What are the contraindication to this?
Now let me give you the 2 or 3 parts. First part is contraindication is when the surgeon is not open-minded. He doesn't want to do. Full stop. Secondly,
neck femur fracture. Proximal to basic cervical. That is
so basic cervical. See, that was I was to ask because I had seen one failure which I have given to Dr. Jigar.
We are going to discuss. We are going to discuss that case, sir. But I will tell that proximal to basic cervical. Basic cervical also we can do endosnail.
Now Jigar, still we have tibia and humerus remaining for the complex cases fast so that people can learn what are the complications.
Sir, I have already sent that PPT also to you. You want to run that?
Yes, I will run it. No issue. I will
I will run
first
from my.
We will do the complication of proximal femur.
That is the case discussion. That is the case discussion.
Okay, I am opening up now.
This way we should have started in the morning 9 a.m.
What do you do if there is a GT avulsion and you need to fix that also? GT avulsion?
Yes. We need to fix it in the
That's a different game.
And now the question about the lower end has come. Anybody has tried SS wire to hold all the 3 nails through their eyes to prevent the backing out?
No need.
All has a question about backing out. How to prevent the backing out? That is their question.
Now let me give answer. Number one is good bend. Number 2 is a turbo screw. Number 3 is that you know that you have put it properly and proper bending has been done. Now I have already manufactured and have tested locking screws, and I have a couple of cases with me where the undernail was modified, where the eye was having some threads where I put this particular screw. But slowly I have found out that simple U-pin, which Dr. Manoj Joshi sir is also doing, is working very well. But when it is a backing out, you don't think of so much of which is a rare complication.
Just like a U-pin in the distal radius and medial malleolus.
Let me tell you,
I have prepared another U-pin, which is the serration, which is I have prepared another staple also, which goes into that. But those are the things which are not that much important.
Do you think that the forces are so much it will prevent backing out?
No.
That is the follow-up. That is the follow-up question came here.
Now let me tell you. Whole world doesn't know what is Z effect. Whole world doesn't know. There are n number of hypotheses. So when there is a fracture where there is some movement at the fracture site, nail might go down, nail might go up. I am not talking about the backing out because of the collapse. I'm talking about the movement which occurs at the fracture site by which this goes up or down. And that is the reason why once you put these screws, to some extent, it minimizes the movement at the fracture site. And thereby you are going to reduce that Z effect, and maybe it is not like zero. Maybe the number will go to hardly less than 5% of the cases where there will be waking out.
Okay, Jawahar bhai.
Sir, to me, backing up the out of the nail can be prevented. I use that technique what I have shown, but collectively jamming of the nail, fanning of the nail, a good subcondylar hold, and an absolute stable fixation in turn will not allow the nails to go down. So you should use all the principles, and that will not give you a back out. So it is all about having confidence over the technique, and over a period of time you will not get the backing out of the nails.
I tried all the
Okay. Now two questions are coming, Jawahar bhai. One question is, when there is a lateral wall combination, how you pass that 7 mm screw?
Yes, that is what I said. Time and again, you have to have a 3D CT scan. If you do not have, if you are not able to catch hold of a good area from where you can pass, then no, don't pass.
Don't use.
Then forget lateral wall fixation.
Okay. Then the next question is, what is the comparative C-arm radiation exposure in other procedure and this procedure? They feel that this is a more exposure radiation C-arm.
They feel,
but it is not like that.
Not.
As soon as you go on doing it, the exposure will be reduced.
Explain it, sir. Explain it.
I'm explaining.
Okay.
They feel it is not, because I have experiences. Why? There are some papers where there is an exposure time also is given. Like if you are very much smooth in putting a PFN, the exposure will be maybe less. But if you have real problem, then there also there will be more. So it is not this method which is going to give every time more exposure. It is the way you have learned, you have experienced. So my again appeal is start doing in two-part fracture. Don't wait for the complex fractures. Then only you will have that confidence and experience by which you will be able to take any of the complicated cases.
So can I add one thing? Navin bhai.
You add, please. Add it. Whatever you want.
For IITV exposure, see, once you start doing it, over a period of time, what happens? You take the entry, and then while pushing the nail right up to the fracture side, there is no need to see IITV. So by that way, over a period of time, you will reduce the number of exposures. Okay. Once you feel that my nail, when I'm rotating it externally, it will go into the anterior compartment. There is no need to see even. So that will reduce your number of exposures. So by experience, it will be almost to the half. It is just like doing distal locking nailing in tibia interlock. That one will need 100 suits and one will need hardly 10 suits.
Okay. So now the question to Jawahar bhai is that a follow-up question from Dr. Mukesh Shah. Mukesh, let me ask the question because audience is waiting for the questions. Dr. Mukesh Shah has questioned Jawahar bhai. Do you use the washer with that screw or not?
Yes, very good question. If the screw is below where there is a thick cortex, don't use it. If the screw is at a little bit proximal to that where there is a trochanter, actual trochanter starts, there the outer cortex is thin, so use it. It is common for everywhere in the body.
Yes, now the question the question has come from Dr. Kapoor, UK. He's saying in the UK, and he says that to the faculty, everybody is skillful in any other method, but in compared to proximal femoral nailing, apart from the cost, is there any difference in comparison of proximal femoral nailing and the ender nailing?
Huge difference. As I told you, it is a happy fixation.
Please say point wise. Please say point
wise. I have shown you what are the points.
Just enumerate, please.
First of all, you are not disturbing any of the attachments proximal thigh, including the internal rotators which you do in a PFN. Second part is that you have a biological fixation which allows micro motion, which the whole world, all the researchers are craving for. And that is the reason why it works wonderfully and compared to any stable or minimally collapsible implants.
Sir, I would like to add, just like ligamentotexis, the word ligamentotexis is very popular. And it is working on the principle of musculotexis. There are so strong muscles around the proximal femur, the abductors, rotators, on the medial side, anteriorly, posteriorly. So that gives an extremely good sleeve of muscles around the proximal femur, which keep the proximal femur entirely in place. Even though the lateral wall is fractured, that Jawahar Jethwa sir has rightly said that forget lateral wall fixation. It's a forget lateral wall fixation. The lateral wall will fall into place once the proximal and distal fragment is in place.
Dr.
So
Siva,
it is highly biological.
Dr. Siva, your comment is required here. Somebody has said, ask Dr. Siva to tell something about difference in
the critics part.
Please.
I was on the WhatsApp. I didn't listen to the question. Please, sorry.
The question was from Dr. Kapoor from UK.
Yes.
He said that in comparison to the proximal femoral nail, only advantage is the cost. Is there any advantage in comparison to proximal femoral nailing with the enders? Can you differentiate between two and give our audience a clear-cut picture of both are different methods and both have a different perspective?
Yeah. You are comparing orange with apple. Definitely, it's a one more method of treatment. Even I have learned a lot today because I'm not doing indus nail to the extent it should have been done. I have been doing only in children for fracture shaft, femur, and but not in any of the intertrochanteric fractures in adults. So you have to master the technique, whatever the technique. Once you master the technique, you can extend your indication for all the complicated cases. Like Dr. Jawahar Jethwa was telling that he puts a screw and he thinks that it is avoiding a sort of Z effect. But Z effects are due to so many reasons. It could be due to longer superior screw which blocks the sliding, or it could be due to osteoporosis or due to shorter cervical.
Yes.
So you have to analyze so many factors. So this is one definitely good modality of treatment which I would love to learn in my next few cases and keep it as a method in my armamentarium. Definitely.
Dr. Navin, can I answer this question? Dr. Navin, can I answer this question?
Yes, you can answer the question.
I am not an enders expert. I have been doing PFN regularly. Now the problematic fracture with PFN is the one that are high subtrochanterics, that have large metaphyseal component, and even after doing open reduction, the nail is not able to hold it. You can make it fix. You can fix it by using an additional plate, by using polar screws. But despite all those things, because of the short fragment, because of the metaphyseal fragment, the nail is not able to hold the reduction. In that case, enders would be of great help.
Let me tell you, Ashish bhai, the two most important indications or the difference between PFN and ender nail would be enders go from down to up, PFN goes from up to down. So particularly in obese patients, it is very much helpful because your knee is going to be thin and it is not going to cause difficulty like the one you are getting in PFN in an obese patient. Another thing is whenever there is a lateral wall breach, you have a big risk of breaking the lateral wall further while taking the entry, and your nail will separate out the proximal femur again. So that is another area where ender nail would be quite favorable. It is not at all seeing the lateral wall. You are just concerned with the medial wall and calcar, and you are resting on the calcar. So that's what I feel.
Dr. Kashyap bhai, you can comment. Then the follow-up question is here. I got the follow-up question. The audience is following very well.
Yes, I have a very similar saying like Dr. Ashish. There is a one area where probably enders is superior to PFN and DHS. That is a reverse oblique fracture of the proximal femur, where constantly PFN and DHS are doing, not a very good thing. And at that place, probably enders have a better edge to it.
Now, I have a comment. The word which is say that accept the cost, forget that. Cost never comes in a science. Secondly, cost is high. When I'm using 7 mm CC screw from Zimmer, each screw costs me between 3,500 to 5,000 rupee. So it is not like something you talk about cost. Cost has been so much in the literature, and that has given us a very wrong idea in our mind. That is not the case.
Cost has never been an indication for doing ender nail.
Yes, never had been indication. Yes.
Okay, now the follow-up question, one good question is that, what do you consider about the quality of the bone? Which quality of the bone is good for enders? Whether it is osteoporotic, the general myth is the osteoporotic old age patient, nothing can be done, enders should be done. That is the question.
Let me answer, sir.
I think reverse. I think reverse.
Yes, absolutely reverse. Particularly in osteoporotic patients, enders being intramedullary load-sharing implants, they are the best one. And you are dependent on the cortical, on the cancellous bone of the head. You just feel that when we remove, and in a neck femur fracture, when we remove the head is entirely filled. Okay, so your ender nail are going in a different direction, and it is like a pot. It is like a pot with the sand inside, with the wet sand inside, and the plant is growing from outside, and it is holding very well. So the same thing, the head of the femur is holding the nails very well, even in the osteoporotic patients. Can you hear me, sir?
Yes. My answer is that a very simple anatomical fact. If the bones are osteoporotic, nothing will hold the way it can hold in a good bone. So it is a simple thing which there is nothing like for osteoporosis, there is a different method. Even in osteoporosis, the way you are getting the hold, but here the advantage is that there is a fanning. There is something which is a bigger area is hold. And that is the way even in osteoporotic, because it is catching a wider area, the possibility of hold increases.
Yes, it is the more square millimeter of area of head which we are holding.
Yes.
And that gives us stability.
Navin, I have the two presentation also, so let's think of, because it is already 6:30 or so.
So I think we should move to the complications or the case discussion part.
Because then the two presentation also will take some time of the tibia and the humerus.
And this is so Navin bhai, we are moving to the first case. Hello, am I audible?
He has made it.
Navin bhai, you are muted.
Yes, muted. No, I mean, he has already put, you said, go ahead.
Because I am muted because there were audio questions. So I have to hear that audio questions. Otherwise, you will hear that.
Okay.
I have audio questions.
So, sir, Navin bhai, can we go ahead with the first
case?
Yes.
Case 1, I have already projected. 70 years male presented.
Just taking your permission.
Navin bhai, do this webinar part 2 also now, I think.
Okay, no issue.
Yeah.
Okay.
So, let me go ahead. Can I, Navin bhai?
Yeah, go ahead.
Okay, so this is the first case. This is a 70-year male presented at 2 months with this X-ray. This is the case from Dr. Krudan Tarya from Anjar. He is my very good friend. It has not been operated by him. So now it is open for discussion. Just next slide, Navin bhai.
Oh no, these only. What is the problem
next slide.
area?
Yeah, just next slide, please. Next slide is showing some. Yeah. So the nails are backed out with knee impingement. So now it is open. So Kashyap bhai, you can answer. So what would be your take on this now?
These cases are for the critics only.
Yes. So my question is, how important is reduction?
Yes.
Before starting the surgery. So as Jigar bhai, you said in your presentation that you reduce your intertrochanteric with help of enders. So I would probably differ there. As Dr. Siva has endless times told to all over India that reduction has to be first. So probably I feel the reduction has to be first with any modality of fixation.
No. Only minute reduction is not there. Then only it can be corrected with enders. Otherwise, if the fragment is absolutely in flexion, you can't expect the ender nail to reduce it.
Can I say some point here? Here, probably surgeon has not made a medial band, not made an anterior band, and it is not giving that flexion of the proximal fragment correction.
It is in situ fixation. It is more of an in situ fixation.
Yeah.
And two big mistake is the length of ender size, and another lateral enders was not in.
So here the principle comes of bending, anterior bending, posterior bending, and use that anterior band to get the reduction.
Put the next slide, please. Put the next one. So the surgeon has done this now. At 2 months, he revised to the nail, femoral nail, and with an added plate with bone grafting. So next slide, please. So what went wrong is, first of all, what Kashyap bhai has said, reduction could be better than this, and one should not hesitate to open. Nail length, as Kuntal bhai said, the nails are very long and penetrating the hip as well as coming out. So the nails were little long. Probably the entry also will be very low, that the nails have gone below the condyle. So these nails probably, if Kanabar sir has to take out, he can take out by arthroscopy. So the nails were not buried inside the cortex, so that it has come out and asked for the early revision.
Enders have also the complications if it is not done in a rightly.
So it is more of a technical failure rather than an implant selection failure. That's what we want to say.
Yeah,
now in this particular case,
intertrochanteric or subtrochanteric fracture, it's a high upper third fracture femur. It requires spindling of the endus nail. So I would have put a medial endus wire and so that it would have spindled at the fracture site to give a good support. So that's
this is principally this is wrong.
Yes.
This is surely a subtrochanteric fracture.
Yes.
So you need a Y configuration.
Y configuration is must.
Yes, exactly.
You do not have, then this is going to happen, and that is the reason why once we understand, then a lateral entry you are also confident, and actually because of the loss of reduction, the nails have been longer. Had it been a good reduction, then nails would have been of the proper size.
Again, a new case now.
Sir, so I just want to support this with a positive case. So just go with the next slide. This is the subtrochanteric varieties, same case, similar case, done with Enders nail again. This is my case, and it has united at 1 year absolutely fine with just Ender nails, and there is no lateral nail. One can see there is no lateral nail, but all the nails are quite subchondral, good fanning, and it has united quite well.
Here, Jigar,
so it can give very good result.
Young patient is there, I think.
There is a one question. There is a one question from the audience. There is a one question from the audience. That typically in a subtrochanteric fracture, it is very, very difficult to go the nail medially in the medial quadrant of the head.
Very good question, sir. It is very difficult to put the nails medially, particularly in the head part. Even in this case, on the screen, you can see that the nail is not going much medial in the head part because the proximal fragment is quite long. Whatever the medial curve you have given, it gets straightened out. So low
subtrochanteric fracture requires more medial bend, or you may not be able to do this. This is an exception.
No, let me tell you.
Just let me, Jawar sir, let me finish. You give more medial bend, it will get straightened, but at the end you will be able to put it in the center almost. Okay, so that will control the head fragment, and that will give you a good stability.
Jawar bhai.
Now you remove this myth. All the time you want on the calcar. What is this? You have multiple nails.
Yes.
You have a good hold. It is not that much essential that it has to be touching the calcar. Yes, if it can be, it's okay. But look at the overall reduction, look at the overall stability, then don't go with that, because there are ways by which you can go more on the calcar, but you have to have good fanning at the end. There may be no fanning on the epi X-ray, but if there is a good fanning on the lateral X-ray, that also will do. And sometimes I put before passing the first nail, I put into valgus reduction so that I can go more medially.
Yes.
So a couple of tricks which you can use.
Sir, what I feel is
Dr. Hemant and Dr. Rahul Katta, do you have any input on this case?
So,
sir,
if I can answer you, Navin bhai.
Yeah.
That is the beauty of this Enders nail, because they are quite elastic.
Yes.
So giving a pre-bend, and when they go in the medullary canal, they act as a spring.
Yeah.
Yes.
So they get a very good hold in the distal and as well as the proximal fragment. So they do quite a good stable fixation.
So,
Dr. Katta, your experience? Yes, I am coming to Kashyap bhai, you.
No, this is a very good fixation. Actually, there is a good fanning, so the hold in the proximal fragment is very good. That's why always there is no need to put all the nails towards the calcar, towards the medial side.
Yes.
Okay.
And the principles of the fanning is very good to purchase a good purchase in the proximal fragment.
Yes. Yes.
And if
Kashyap
you really see this X-ray, then the nail, the first nail that you are seeing, is dead in the calcar region only. It is in the head that it is going.
Yes, in the center. Yes.
So it is just connecting the calcar.
It is buttressing the calcar. Yeah.
Yes, it is one more thing. See, Enders is not an axially stable implant in long axis. So when there is a circumferential comminution in any fracture, so probably that is going to be inherently an unstable fixation. So in this case, which you have shown success, is a 2-part fracture, while the previous which was failed was a 3-4-part fracture. So when there is a lot of comminution circumferentially, probably enders may not have that advantage of the PFN, which are a length stable implant.
No.
Sir, we will see few more cases as well, sir. And I have already shown enders in comminuted subtrochanteric fracture as well. So
okay,
sir, let us move to the next slide.
This is 1 year follow-up, and this is the result.
This is the result. And see, he is a very young chap. So it's a myth that we can use only in old patients.
No. The comment here came to me is that it was a young patient, good
That's
bone,
why
so
you
got the result.
Sir, we have already shown similar results in old patient as well. In my previous presentation, we have shown in 71-year male.
Jigar, this case, you have reduced the fracture well and put the first enders, and other enders you are used to fill the gap. But in the first case, what the surgeon has done is he has passed the first enders nail in an unreduced position, and he has just pushed a few more enders. The crux of the treatment here is getting the reduction properly.
So reduction is the crux.
Absolute reduction is must. Absolute reduction is
for,
must.
For any implant method.
Any implant.
It's a universal truth.
Either you get it prior or you get it with the implant, but ultimately absolute reduction is must. This is the second case.
Navin bhai, the impaction at the fracture site is very important.
Yeah, impaction is also.
This in second case, there is good impaction.
Because there was a good reduction. When there is no good reduction, impaction is not possible at all.
Yes. And it will lead to shortening as well. So another case, let us move to the second case. This was given to me by Dr. Kashyap sir only. It was not operated by him. First case also was not operated by
anybody wants to comment on the fixation?
Let me comment.
Dr. Patil sir, let him have a contribution from Patil sir from the Pune.
Yes, sir.
Yeah, what is your say in this fixation, sir?
Sir, in this case, actually reduction has not been achieved prior to the fixation, prior to the endothelial fixation.
Anything else?
And I think the nail size is also less. Actually, a reduction should have achieved first, and then 4 nails should have passed.
Okay, here only 2 nails are there. 2 nails are there.
Yes.
With at least 3 nails or 1 nail to the lateral side at the engaging greater trochanter.
I would like to add something. See, this is the case where putting the lateral nail might be little bit scary because the GT is about 2 avels. So there is not always must to put a lateral nail. That's what I want to say.
No, Jigar. There you can put a CC screw.
CC screw, yes.
And make it that lateral wall. Yes, make that lateral wall little bit stronger.
Yes, absolutely right.
But my comment on this particular case is my comment and appeal to all the moderators across the whole world.
Don't
take such cases where initially it is not a complication.
Yes,
something
it is not a complication.
Done. So why
technical failure? Why is a technical failure?
So why my point is very important. Any of the conferences or discussion, put something which is done reasonably well, and then there is some problem. Otherwise,
sir,
do you
feel
that
we did not have that kind of case that done well and has gone wrong?
Yeah,
that's why.
Hello. This is not day 1 failure. This is a first minute failure.
Sir,
well said, sir. Well said.
Can anybody mark the entry here? He has made a small entry and he has broken this medial cortex.
Yes, there is a big splinter. There is a big splinter as well. Sir, go to next slide. Sir. So this was done by the next surgeon. Again, not operated by Kashyap bhai. So what is the comment on this? But this is the position. So the next surgeon also was probably not knowing proximal femur much. So go to next slide. People have seen already.
Lateral wall is not been taken care of.
Yeah, go to next slide.
Whenever you go for...
the blade is absolutely out posteriorly.
Okay.
So now you can blame both the implants now.
Yeah. So now go to next slide. So ultimately implants were removed. Patient got tired and no further follow-ups. So go to next slide. So what went wrong? It was almost a day one failure. Only 2 nails for such a high velocity, high force, having subtrochanteric fracture, no jamming, no fanning, no resting on calcar, better medial bending was needed, improper length of the nail, and no reduction at all. So it was a technical failure rather than a failure of the ender nail. So we can go to the next case, sir. So another fracture, say a similar fracture. Next slide. See, here I have put a lateral nail going into the GT when I felt that it is holding well. Next slide.
Gamma configuration.
Yes,
configuration.
This is gamma configuration or Y configuration, and it is holding very well. See the union. See the quality of union it is having at final follow-up. So if done well, keeping all the principles in mind, you can see one short nail as well. So that is adding to the axial as well as rotational stability. Yeah. So all the
nails. That is turbo nail.
Yes, and this is at the lower end. And go to next slide. And this is having full flexion of the hip and knee, and patient is able to sit cross leg. So now next case, another case. This is given by Kashyap sir. So suggestion.
So sorry,
go
but
back.
This was not a 90-year lady. It's a 60-year male.
60-year male. Okay, so probably you have sent me that.
I got at this stage. It was a 60-year-old male.
Yeah.
Okay, it's corrected.
So this is the only CT pre-op CT we have. And so what would be the comments from the panelist? Kanabar Sahib, what will you do for this case? Nana Sahib. Sir, this is open forum.
Sir, speak in English so that all the audience in the south also gets your message.
So I got them a laugh,
Okay.
No, let me give a very important comment on this.
Here combination is there, and probably it is a bifocal fracture with the basic cervical element.
No, yes. Very important thing is, if the posterior wall of the neck is not intact, don't think of any fixation. The posterior wall of the neck has to be intact. It seems like posteriorly there is a comminution, so maybe anything you put, there are all chances that it will come out. These are the cases where you have to be so careful in putting all implants anteriorly or directly to go with a calcar bearing bipolar.
So let us go to the next slide.
Sir, can I comment? You're absolutely right that for the fractures in which posterior comminution is there with basic cervical component, it's difficult to get hold of the good implant. The proximal fragment just separates by itself. But what I have seen is that inter-10, the screw in which the screws are in figure of 8 configuration, they are locked screws. And with inter-10, I have been able to get good results in these difficult proximal femoral fractures with difficult comminutions.
Okay, but it's a fixed angle implant, so it has its own problems.
Yeah, it has its own
we are not discussing
another conference is needed.
Okay, now
so this was done by the primary surgeon.
Jigar bhai, should I take at this point?
Yes, please, sir. It is your case.
This CT is not actually day one. This is the day one X-ray where I inherited this patient.
Okay, fine.
But because I wanted to evaluate the condition of head, I got that CT done. Whether I will be able to fix it or replace. So this is the day one X-ray which I got.
Okay.
This was the day one X-ray with the enders in. CT was done with the enders in.
Yes.
And CT was done to know the condition of head, whether I will be able to fix that or I will replace it.
It is only a 3D. There are no sections. Otherwise, we would come to know.
Yes.
Yeah. Okay.
So finally, this was done. And go to the next slide, sir. So what went wrong? Everything was wrong. Probably wrong indication. It might be a very high fracture.
So can it be a contraindication to do enders when the length of the proximal fragment is very short?
Yes.
That is a contraindication.
Clear message. Yes, that's a clear message. When the fracture is proximal to basicervical and you don't find a very good proximal fragment, or it's a basicervical with much comminution, probably you should not go and attempt for this. Let us see a similar case.
But Jigar bhai, would I like to ask?
Yes, Kashyap.
Do you recommend enders in a basicervical which is simple? Because I still doubt.
Let us see the next case. Because the next case is similar. Basicervical.
This is not basicervical. This is a different kind of high velocity intertrochanteric fracture with the lesser trochanter, which is high riding, and there is a psoas intervention. These are absolutely different ball game. What I'm asking.
Here possibility, the possibility
comment.
of psoas is also there.
Yeah, this is a different ballgame.
No, as far as the basic cervical is concerned,
yes,
if the lesser trochanter is with the distal fragment, and major part of the trochanter is intact, there is no need to go for this modality.
Yes, DHS
can we complete the cases? Then we'll discuss, because so many questions are coming, sir.
No, you have to put somewhere you have to go fast, because there are two presentations.
Yeah, I know. That's why.
Let us move ahead. Sir, so similar case, it was probable was interposition.
Jigar bhai, just enumerate the principles by cases only.
Yes.
We'll not discuss by each and every faculty, right?
Yes. Go to next slide. So this was the immediate post-op X-ray with this reduction and with these nails. Next slide. So at five, this is 5 years follow-up, and it has absolutely healed well, nicely. And next slide. And this is the final clinical follow-up. No external rotation deformity with full range of motion. So even at when the lesser trochanter was not there.
So it is a adaptive implant. Adaptation has occurred gradually. The adaptation has occurred. It is the adaptation.
So it is the intact muscle sleeve around the fracture which has allowed collapse as well, and the fracture has healed absolutely nicely. If the principles have maintained.
But we are not having the lower end, because the collapse has occurred. So the
next slide would be having.
The collapse, the nails must have gone down.
No, it is hardly a centimeter, sir. It is hardly a centimeter. So you will not even find it in the distal end. The next slide is having the distal end X-ray.
But it was scary. If it has moved inside, it was created a problem.
Yes. So that is very important.
Again, here the argument is it was a good quality bone. Otherwise, it would have gone inside.
Yeah,
remember, there is a wrong
possible.
Comment. There is a wrong
particularly,
comment. If you don't fix distally, it's an advantage.
Let me tell you one thing, sir. When we have seen that if there is a foveal penetration, but there is no joint penetration, still patients do well, and it is not causing any problem. The similar case has been given by Dr. Patil yesterday to me. That patient is having day 1 penetration of the fovea, but even after that 1 year follow-up, the patient is still having foveal penetration, and there is no problem at all. No impingement.
He mentioned it. You mentioned it.
So
sir.
if your stability of the fixation is good, your nails will not move much. So go to the next slide.
No. There is one good message which I want to convey.
Okay.
Do not think like it will go penetrate into the proximal part. There are multiple nails. It is not that one nail is making a way to go inside the joint.
Yes.
All the 3 nails will never ever go together. Unless.
Yes,
when you are doing
that question has come.
When you are doing this particular procedure,
you have penetrated once. You
do distal locking.
No. What Navin bhai is telling, that while doing the procedure, if you have penetrated previously, but your post-op X-ray is not showing, that does not mean if you have penetrated the joint operatively, it will go. It will go later.
If you have shown the nail the way, it will go that way only.
Otherwise, all the 4 cannot go up.
Absolutely right. But
let's go to the next slide. Next. So this is my case. This was young male, a long spiral fracture, comminuted subtrochanteric, and one can see that the fracture line was quite extending to the greater trochanter. I tried to do PFN because this is a very big proximal fragment. First choice has to be a nail with 2 screws going in the neck. But even after
Jigar bhai, can we comment? You tried to make a joystick with the reduction of external rotation and flexion of the proximal fragment. This looks like a joystick here.
Yes. I have put up a Steinman pin in the proximal fragment. I tried to do it, correct the external rotation of the proximal fragment and have medial entry of the nail, but the fragment was still remaining in abduction with unacceptable reduction. So we opened that case. So ultimately we opened it, but still was hard to reduce even after opening. So next slide.
Just because of, I think there was a buttonholing of this muscle here. Buttonholing was not allowing you to make the reduction. You have to remove this buttonholing.
So even after opening, it was a bit difficult to put the nail. It might be like that because I am not doing much of the PFNs or proximal femoral nail. That's why I was not able to do it, or it was actually difficult. So next slide.
Even with the PFN, you may require a open reduction in these cases because of the buttonholing.
Yes. So this was done finally. So what's your comment, Kashyap bhai? What is your comment? Is it okay?
So, like, as you said, there is a learning curve with enders. There is a learning curve with PFN also.
Yes.
So probably it was in the learning curve of your doing PFN that you couldn't do it.
Here the beauty.
But I would definitely say enders is a rescue implant. See, I don't do enders much, but I always keep enders on the backside because sometimes it can help in such situations.
Yes.
Oh, it's the most forgiving implant. It's the most forgiving implant.
At least you can finish up the surgery, which is otherwise.
I would like to comment. See, for this case, my first choice of implant was recon nail only.
Yes.
Okay. So we tried and started with the nail only, but this is the 5 months picture. So what next? What is it fine? Sir,
no,
go back,
fine.
sir.
It is not fine because
bail out because you have circumferential wires.
Fracture is not united probably.
No, you need to have Y configuration.
Yes, you need to have a Y configuration. That is the only message.
And this, whatever the tension band wire, it should be temporary for reduction. It has to be removed. Otherwise, it will occlude your blood supply to the. It will hamper the biology, local biology.
Not agree. Not agree
fully.
with that. Not agree with that.
Sir, that concept is not there. No longer there, sir.
No, yes, sir. I don't agree with that, sir.
Yeah, even I don't agree.
Strong virus force because of the third butterfly type of fragment. So these are the cases where you have to give a counter force by a lateral nail.
By lateral nail, yes.
But that tension band wire is not taking care of that lateral force. It is holding. It is holding the
tension band. That is only counteracting hoop stresses.
Let me add one thing. What I have seen is when the proximal fragment is much long, even with enders nail, as the enders nail are not that stiff, that bending force will give a varus failure. So these cases are the cases where you have to have a lateral nail to counteract that valgus force or a varus failure.
Okay.
Yes. So next, ultimately the patient went to some other surgeon. They removed the implants and see one nail has broken.
Okay.
One nail has broken.
Why is there? Was there an infection also?
No, there was no infection. And what I felt was at even 3 months, it was easy to counteract the lateral force by just putting an external fixator of even one pin. That also could have worked because otherwise the fixation was quite good. So next slide. So at 1.5 years, this was the story, and fracture was almost uniting. After that, I have not seen the patient, and the last surgery was not done by me.
There is definite shortening is there.
No. Yeah, absolute shortening is there because I don't think that Elizera was needed. It was much done things for this patient.
No, very important comment which I want to give. When you have such a comminuted fracture, by opening it up, you are damaging the vascularity so much.
Yes.
So what you have to do minimal and then try to protect the biology.
Yes.
And that is the reason why you have to understand and you have to, put a
Sir, go to next slide. It will clear everything.
Is there any relationship between the distance between the two loops of these wires? It should not be very near to each other. Is there anything?
I think here it was just to have
because
one loop for the proximal fragment and one loop for the. Sir, here the one loop is for proximal fragment and another loop is for the distal fragment.
Okay.
And the medial butterfly was holding with both the fragments. That was the reason here.
What if you already opened up? You could have passed submuscular plate, long plate from proximal to distal to get the rotational stability.
I was not having it. That was the reason.
So it was not planned properly.
Yeah, it was not planned that it can go this much difficult. Even adding just one pin proximal and one pin distal external fixator also would have helped nicely.
Yes. So many times enders requires augmentation or a plate requires enders as augmentation.
No, it requires only when you have not understood and put a Y configuration.
Yes.
You put a Y configuration, nothing is required.
Sir, let me tell you, Jawar sir, for this case, Y configuration is always there in my mind whenever I am doing a subtroc case. But while putting the third nail, it was very difficult because it's a young patient and the canal was not that wide.
It happens.
So
it happens.
for me, I had to do just 2 nails medially and 1 nail laterally. But still, it was not possible for me to put that lateral line. That's why we put medial.
Is it Jawar be possible to put from the proximal to distal?
Yes, yes, that is the trick. So instead of 3 on the medial side, put only 2, and the third one you can pass from proximal entry at the tip of the trochanter, which is all solution when you have a problem.
Yeah, I think so.
Yeah, but that should be limited to only few cases, sir. That's what I feel, because otherwise it increases a lot at the proximal.
These are much more finer points.
Yes.
So can we go next?
Yes. Just pass on fast.
So this is another young patient, butterfly fragment, and healed very nicely.
Beautiful.
Okay. Yes. So it is not every time that it will fail. It is sometimes when the proximal fragment and the luck is not favoring you, and the biology is not favored.
Only my comment is you have to remain vigilant and get the good follow-up of these patients.
Yes, absolutely.
Absolutely. There was good valgus. That's why it has been. Earlier case there was a varus.
It was in valgus, yes.
No, sir. In that case also, on day 1 it was absolute valgus.
Yes,
but
Kanabar, sir.
In
proximal fragment was so big that with weight bearing, it has gone into varus failure.
In science, we don't talk of luck.
No, it is not luck, sir.
Sometimes only.
Yes, mention. Yes.
Sir, so another case, bilateral intertrochanteric with subtrochanteric fracture, and bilaterally Ender's nail were done. Go to next slide.
But this typically happens with the subtrochanteric. One nail looks like it is going outside the neck.
Suprolateral. That's a suprolateral penetration.
Partly going out of the neck and irritating.
It is borderline. No, it will never irritate, sir. It will never irritate. It will just hold. It is in the cortex. And this is the final follow-up of that patient, even with bilateral. So another case. So go back. Just let us comment on this slide. That was 70 male, 1.5 month old fracture. This was done by somebody else. It is not my case. Next slide. So at just 2 weeks
it has gone into the virus. It has gone into the virus.
Just 2 weeks follow-up, and this was the situation. So
again the bone is osteoporotic.
Again, as per
Neil bhai, what is your opinion?
Okay, now can I give you opinion?
Yeah, please.
Sir,
here is where you require CC screw augmentation.
Yeah.
So that you have a better hold in the neck.
Nehal bhai, unmute yourself. Nehal bhai is muted.
Yes, okay.
Yeah,
open.
Now you can speak. Yeah.
Fine. The nail might have migrated backward towards the knee. So a hold in the head has been lost. So it has gone into varus. And
Navin, put the next slide. Put the next slide with the failure. Yes.
Yeah, this is the picture where IIT image is seen. Nails must have migrated towards the knee. So hold from the head, subchondral purchase has gone. That's what I think.
Navin sir.
Yes.
As per discuss in Rajkot Goa negative reduction and positive reduction, that principle we should consider in the mind.
Yes, that has to be considered with all intramedullary implants. Yeah.
Sir, so this is what the surgeon did. Sir, go back one slide. So he just added one more nail to jam the wide canal. A better valgus was achieved.
Or two added. No, one only added. Okay.
One only added, and he has kept the.
Can we now switch over to tibia and humerus so that we can have a time for that, because 80% time will go to the proximal femur.
Yes. That is
we want to deal with the tibia and humerus also, sir.
Navin bhai, can we have a separate session for tibia and humerus? Because
no.
Because so many webinars have been planned, so it is very difficult to have a second webinar.
No, let me tell you, 7 webinar on only proximal, 7 on only subtroch, 7 on tibia, and 7 on humerus. Huge subject. Don't think of it can be.
Sir, if you don't mind, sir, Navin sir, if you don't mind, I will just finish it off in 10 minutes.
There cannot be any crash course.
Sir, Navin bhai, if you allow me, I will only speak and I will show all the slides so that people can see what were the complications and how to get rid of it. So we can just
10 minutes. Let that part over, then case is over. then proximal part they've understood, I think, very well. All the points are driven. So let us go for the tibia and humerus, because people are not knowing how to use in the tibia and humerus.
Sir, I think audience must have been too tired by now.
Okay.
Because the time which was given was 4 to 6 and now it is 7 o'clock.
Navin bhai, can I leave?
Yeah, you can leave, sir.
Thank you.
Okay, sir. Jawar bhai, can you take over the screen,
yes,
please?
Yes, we have
please,
to be,
please.
because there's something now. I don't know what is this stops either screening. Yes. Okay.
Yes.
Yeah,
so now I go to
share the screen.
Share the screen. Before that, I have to go
you have made your video off because of the signal, I think.
No, I have not made it off.
Then
it is already off for so many times. I don't know.
No, it was done. I'm asking you to make it on, please. Make it on now.
So how do you make it open?
What?
Click on that stop video button.
Start video option.
Left bottom.
Left bottom, start video. Near
Okay,
the mute, right side to the mute.
Okay.
Yeah.
So that people can see you.
Yes.
That's
why. Okay.
Now share the screen. Share the screen, please.
Now let me first open up this particular presentation on tibia.
Share the screen. Share the screen.
Okay, I'll just do it.
Anyway, if the audience is
It is
tired,
open now.
It will get recorded and they can see later on also.
That's correct.
That is the advantage here.
So all right, I have opened
we don't have the privilege to be tired.
If the faculty is tired, it is a different case.
No, that's not an issue.
2 cups of tea.
So you are on the air, and during the air you will not say that I am tired. I know.
we started after lunch. We will finish before dinner.
Yeah. Okay.
Yes, so it is lunch to dinner.
Okay, if I start with this, is this the tibia nailing you are able to see?
Yeah, yes, there was some technical issues that were now everything is seen. Sir, go fast, little fast.
Now that is the point. If you want to learn,
you have to go slow.
Yes.
Go ahead.
Where you do not think of so much.
Yes.
Because it's something which I am going to tell. Now let me just start with I'll be fast because we are not going to discuss a lot on both the presentation, because there may be some question we can answer afterwards. So NLL tibia. Further you look back in the history, the better you understand the future. What do I mean by this? The whole aim is only union, and union occurs by the body and not by the you. So well-reduced, stable, flexible fixation that leads to newborn formation is the aim. You have not to think of anything else. So what does the literature says? People say that endoneling is done only in Gujarat. No, it is not true. Across the world, literature is available for endoneling of tibia. Starting with the Japan, there are 14 cases, and they say excellent, technically simple, rapid bone union, no knee disturbance. Then you go to Greece. Greece has taken this for 143 cases, and it says rapid healing, no non-union, almost normal limb functions. Then you go to Italy. Italy have got 32 cases, publication, union in all at average of 13 weeks, rapid union, no infection, no significant malunion. Again in Italy, there is a study of 50 cases where it says procedure has biomechanical advantages, early weight bearing allowed. Then in London, UK, 68 cases of with 30 polytrauma, and it says that excellent result in 95% of the cases. No infection, only 3 non-union and 2 malunions. Then we go to USA, Tennessee, 63 cases. That was in 1989. And there is an endonailing proved to be as effective as external fixator. Avoid endonailing in comminuted fractures where tibia may be shortened. Then this is again in US in 1990, where they have said that endel rods, an excellent alternate for open fractures, allows maintenance, length, alignment, rotation, and is facilitates healing. So don't think of rotational problem because that has been with the developed countries, they have talked about it. Now 33 cases again in Washington, DC, where there is an energy with no varus malunion, early void bearing, early non-union, early union. Hungary, it says with the 46 cases, helpful for distal third fractures, shortened stay, low infection. So even for distal third, people have approved it. Again, California, 1992, 80 cases where provides good control of unstable fractures, use multiple pins, pack the canal for rotational stability. Then again in USA, 1993, 46 cases where they have said low incidence of complication in stable, provide effective fixation, use with a caution when no inherent axial stability. Very, very important message. Hanover, Germany, they have this particular comment that when you compare with other modality, undernail with lotte, there is a low infection mechanically insufficient, but the infection is low. That is what they say. They are not very much happy with this. But the rim unlocking, they have high infection rate. Rim locking nail, they have rely on interlocking screw, which they are not happy with. Undream nail, they are having a screw backage. So there are good amount of observations in this case. Then I presented in 1999 34 cases where I say that this is a sound stability, infection rate is low, union is 100%, delayed in 7, malu in 9, and it is cost effective. Then in Japan, 2000, 275 cases of undernailing in tibia. Look at this, 274 united. Adequate elasticity, much callous, good union. They are happy. Then you go with the Tehran, Iran, where 56 cases have been talked about, 22 closed, 34 open, with a 55 united. Nails irritation is only in 5 cases, and if used correctly, it is an effective implant. Then you go with Brazil, 2007, 24 cases, and 90% of interlocking nails at 1 year only, while in undernail it was 96% healing. So both are similar, that is what they say. Iran in 2008, 64 undernails, but hospital stay union time higher in interlocking nails, non-union and infection more in undernails, no significant difference. So they have left it open to the surgeon's choice. You can do both of them, no problem. Then go to West Bengal, 2015, 15 undernails, and they say, look at this, operative time was lower, almost half, 41 minutes. C-arm time was very low, only 18 compared to 49 in interlocking. Undernails is easier, indicated for selected fractures only. Then Canada, we just don't think of this. We always talk about it is only in Gujarat. No, in Canada in 2015, there has been a study where it was a network meta-analysis and they found that undernailing was superior to external fixator. Undernailing is good for axially stable fractures. In Navi Mumbai 2018, with a 20 interlock and 20 undernail, it's an alternative modality, stimulates scalars, good stability, early weight bearing, good outcomes. And in Navi Mumbai, again, this is the case where they have shown what exactly they have done. I have done the undernailing. So my friend, we need to have a good clap of these all past workers, because across the world things are happening. It is not that you think of only it happens in a particular. So from bad judgment comes good experience. But remember, from bad experience also comes good judgment. So you have to think and find out the solutions. So my appeal for the undernailing of tibia is, what do you select? You select diaphyseal only. When you become expert, you can go to metaphyseal area as well, but not intra-articular, only extra-articular. Then you go with a stable, good cortical alignment. May it be like this, or may it be even segmental. There should be good cortical alignment and it should be axially stable as long as possible. What do you want to avoid? Multiple fragmentary, no inherent axial stability. And when the cortical intactness is less than 30%, don't do it. And in an old case where the canal is blocked, don't try undernail for the revision. So what is the principle? Very simple. Fanning at the proximal end and press fit fitting in the middle part, and again fanning in the distal end. Now this is what has made a big difference compared to the older undernailing which was done. So the sequence can be, you pass the first medial nail right inside of the medial malleolus, not above, because you want derotational force. Then from below, lateral nail going to the posterior part of the lateral condyle. And then the middle one, which is from just medial to the tibial tuberosity to the posterior malleolus and not in the center. These are the very important aspect. So extended indications is like unstable tibia. If you have, then you are lucky if the tibia fibula is not broken. If the fibula is broken, you try to fix it with a tortuous titanium nail. Again, another webinar which is required. What do you mean by tortuous? And or you can go with a plate fixation. But once you stabilize the fibula, then there is a chance in a given case where there is too much of a soft tissue problem, you can think of Anders. These are all extended indication, not the primary indication. Now, this is a very important principle. This is called a victory formula. If you have a fracture like this, don't put medial nail first. It will displace the fracture. So what is required is try to pass the lateral nail first and it will reduce it. And this is the way you are going to get the best of the reduction. Similarly, if the fracture line is on the other side, don't go with the lateral nail first, and it is not going to be give you a good thing, but you try to pass the medial lateral nail, medial nail first, and it will give a good reduction, and that is a good thing.
Jorby, that means the apex of the fracture to be seen.
Yes. Now, what workup you have to do? You have to find out that there is no intra-articular extensions and you have a sufficient wide canal. As Jigar said that you are not able to pass number of nails, then it is not the case for under nail. You have to have a sufficient wide canal, more than 30% of circumferential good cortical continuity after reduction, and there has to be a axial stability. Then let me go through one case. This is the case where there is a almost middle third fracture, which I have shown, which are the bony marks, and then you need to have a pillow below the leg to see cross table C-arm view. If you do not have, do not start the surgery, because that is the point where you go on rotating the limb and you try to see and everything is messed up. So this is the case where you put a, just a moment, sorry.
You don't use fracture table?
No, no fracture table. Okay.
So you want to show video? Okay.
It will start. So here we put a medial incision, just dissect the tissues. With a sleeve, you try to make a drill hole. With an awl, you make a hole on the medial side. You make the first nail bend so that you want to maintain varus at the fracture side. It's difficult to maintain varus even in interlocking nail. Then you push it like this and you have to really hammer, and at different places where the assistant is helping you for the reduction, you go on pushing it, but in between you try to rotate so that you know that you have not pierced the cortex in the proximal fragment. So this is the first nail. Now let us see how the first nail goes. The first nail, you have to able to put the sleeve where you want to put the entry, which is much lower than you think, because the whole eye of the nail is going to be proximal to this. It should not irritate the joint. So it is the right side. Then you put the owl. Then you superimpose the nail and try to find out which is the best size. So distally you have superimposed, proximally you superimpose, you have selected. Then you start passing from the proximal side, and at this level try to see that the nail has started curving. If it has not started curving, either you go with a thinner nail or you bend it little more. And here is the fracture where you try to negotiate through the fracture. And there are all times where you see some distraction, so you know that you are touching the distal fragment. And if you are not careful, it will go out. Then in that case, withdraw it, rotate it, and then you go further. And this is the way you put the medial side. Now let us see on the lateral side. So lateral side, you go little anterior to the fibula, whereas as far as possible go with the lateral distally, not proximally, but there are cases where you have to go from proximal also. Then you make a hole, and that hole has to be in the center in a lateral view. That is why the pillow is required. So make with an owl. Now here the lateral nail has to be E-shaped. It is very important that you do not want valgus. So you want to allow good normal varus. So this is E-shaped. More than that, the proximal end is bent posteriorly because we want to catch hold of the posterior condyle laterally. And that is the way you can have a very good fanning. So this is a very important step where you try to bend the nail properly so that you have a best of the fanning and grip. So this is the curve which is for the entry, and this is the curve which goes for the posterior side of the lateral tibia. So here you can see that the nail is inserted. Now this is very important. Now I am rotating it in the lower part so that the nail goes in the posterior condyle of the tibia laterally. Now let us see what happens on the IITV. See, this is where I mark the entry point with the drill sleeve. I make the hole, then we go with the awl. I confirm always in the lateral view that I am in the middle of the tibia, not anterior, not posterior. And then proper size is selected, nail is passed.
Just a minute, just a minute.
Sorry? Okay.
No, they are
okay. Okay, now you pass the second nail, and then second nail goes on the posterior side. Look at this. It will go and place it on the lateral side, I mean in a lateral view on the posterior side. So this is the way you have got a very good reduction with the two nails. Now many a times two nails are not sufficient, although everything looks very much good. So we go with another third nail which is anteriorly, just medial to the tibial tuberosity and just distal to the tibial tuberosity, and you have to have 3 fingers distance between the two incisions, and there also you make this particular drill hole with a awl. Now this time you have to bend the nail, which may be of a smaller size than the previous two nails, in an S shaped. This S shaped will start from the proximal anterior part and will end up in the distal posterior part. So this is again a very important step where you go like this, and then at the end you can have a compression and you can have all sort of an apposition of the fracture so that you can flex the knee, and then you put position. Now look at this, what I am doing. I have curved the eye little bit posterior so that when you do flexion it will not hurt the subcutaneous tissue. So all these minor points have been added, especially the contouring, and you can give some thumb if you feel like in between whenever you feel like. So what we are doing on the IITV, the site is selected, the drill is there, then you make with an awl an entry, and this is the nail which goes like this, and it is at the center in AP view, and look at this, posteriorly it is coming on the posterior malleolus, and this is how you are getting a very good fixation, right? Now this is all the checks in the different views. You can see that there is a fanning upper, fanning lower in lateral view, in AP view, in AP view, in lateral view, and this is how you are able to ask the patient to bear weight on the second day. The ambulation can be started, and this is how you are going to get the fixation at the end with a good healing. And this was also a compound grade 1, and even if we have started ambulation at day 2, the 10th week you are able to see the callus. This is the beauty of this implant. You cannot see such callus, radiological callus on 10th week with such a compound injury with this thing. Yes, there are cases, but it is not that common. But this happens because of the micro movement, and this is what is happening at the end. Now here, the good marrow density, when there is a good marrow density, this is the case where you can go with only 2 nails, but you know that the marrow density is very good, and this was when the patient was at the age of 22, and I have taken these all pictures. Even after 20 years of follow-up, he is happy with this. Now look at this compound grade 3B, and you know I have shown you so many papers. Here very important part is, as long as you are able to have a cortical good alignment where it becomes axially stable, this patient will do very well, because a horrible compound fracture with so much of contamination, you have n number of complications in your mind, and this is the case where a beautiful healing occurs because there is an axial stability which has been maintained. One proximal nail was removed because it was irritating. Otherwise, patient had a fantastic. Now, one more thing which I want to tell to all the viewers, that whenever you see somebody's presentation, please see the final result. N number of speakers, they just don't talk about this. They talk that the patient was fine.
Only X-rays are not allowed.
Not allowed. And then you don't pick up those messages unless you see, because it is not the era of only documentation, it's the era of medico-legal. Patient is going to ask you whether I got the movement or not. So none of the publication is now worth unless they show final photos.
Clinical results.
Clinical result is the photo, right? Now, this is the case which a compound grade 1, a very bad area where we can pass another things. Here, sometimes I use this U pin for the proximal part, and this is how it goes with a good final healing and with all the movements. Another case, 12 years of follow-up, only 2 nails, given a fantastic result in upper third, which was fairly unstable. One more case, actually very good, where we are able to fix this, and there is a good union. Although anteriorly, it seems like maybe there is some part which is not healed, but it may take time, but the overall functional movement is full. Now, these are the cases where you need to learn tibia undernailing, because you have soft tissue problem. This patient has a lesion, skin lesion, which was going to go for osteomyelitis if you do not know how to do enders. So these are the cases where you do all interlocking in and plating, but at the same time, if you know how to do this, then you can save such patients without any complication and extraordinary healing. Another case of 85-year-old lady with so much of osteoporosis, with so many problems where they were only able to give block, there is no anesthesia possible, where I have passed 4 nails and this is the result. Another more case, multifactorial, where there is a axial stability, and again you get a very good result with that. One more case where sometimes we have to fix up the posterior fragment. As time and again everybody has said that reduction has to be good, has to be stable. So in this case, I had to put 1 screw just to hold the posterior fragment. And these are the extended cases. These are not the cases for the primary. So once I know that it can be done, then I have done the undernail for the proximal part. Here it is very important in a distal third fracture. Once you have done a very good fixation of the fibula, then once the fibula is fixed well, it is not that much unstable. You can go with enders and you can have such a good result at the end. Now, in our Kathiawar, as Kanabar Sahib already left, but let me talk in Gujarati, Narano Gha ane Tadano Cha. That means somebody would say that 6 મહિનાનો ખાટલો થઈ ગયો because it is a lower 1/3 tibia with intact fibula at the age of 75 years with so many other comorbidity. What you can do this undernailing the way I have explained, not simply putting in anywhere. And then what happens? There is a callus is 32 days. Look at this, the effect of micromotion. Can you believe that lower 1/3 with intact fibula with 75 years of age, you are able to see something on the X-ray at 32 years? This is because fanning in all 4 views. There is a fanning epi, lateral, below, above, everywhere. And that is why you are getting a good result. And this is the case at the end of 6 months, a complete healing with all movements normal. Patient is happy, we are happy, and that is called happy fixation. Segmental fractures. Yes, these are very difficult cases. So these are the cases where you go with a fixation like this, where you try to do percutaneous some fixation. Although this particular video is there, but I'm not going to take very long time. There is a different steps which are there in this particular video. But the problem is that it will take long time. So ultimately, this was a fixation by 2 pins only, which I have used as a manipulation stick. I don't like the word joystick because there is nothing to enjoy. It is a manipulation stick. So with the manipulation stick, I am able to reduce the fracture. And this is with a couple of sutures only we are able to go with. Another case, lower 1/3, but a young patient where you can go with 2 nails only. And because it is a very good reduction, you can start weight bearing so early. And the whole, the final functional movement would be very good. This is the case, which is a segmental again. Look at this. What is the versatility of this implant? How this flexible implant accommodates all this fracture. And look at the fixation with this 3 nail. And thereafter, if you see very carefully, this is what is the, sorry, this is the one. Okay. This is how they are able to do next, on the 3rd day. Look at the quality of fixation. Look at the way he's doing internal rotation. He's doing SLR. So this has a fantastic way of fixing because it is elastic. And this is at the end where there is a good union and he is having a full function even in a segmental fracture. Now, another case, and this case which I want to show is that the technique of removal of nails. This was the fracture which was fixed with the 3 nails, and at the end it has gone for a wonderful fixation, I mean wonderful healing. Now in these cases where there is sometimes patient has a mentality to remove nails for whatever the reason, the one we want to remove nails, put percutaneous small K wires and try to target the eye region under IITV, and along that K wire you put the incision, the job would be very easy. And this is the case where after removal, look at the anatomy restored in such a fracture and the final result where it is 100% anatomically, physiologically back to normal. Now, this is a very important case where there is an unstable fracture age 53 with a compound grade 3 with a deglowing with the skin loss. And look at what one Anders has done. I have passed a tortuous fibular titanium nail, and then I have passed 300 nails with a maximum hold. And this is at the end, complete healing. And this is 15 years follow-up. And this is how patient is back. Look at the original injury and look at the final result. And this is very important, how to pass the tortuous nail so that we can have a better hold in the fibula. So again, this was the injury and this is the result. Another fracture where there is a segmental fracture, and here the aim was to protect undisplaced fracture because there is an undisplaced fracture proximally and the displaced fracture distally. So what I did, I put an external fixator where in the proximal part I fixed it so I do not allow any movement when I pass the enders, and the distal part I put another pin so that I can distract only the distal part when I want to give traction, and then I got a very good reduction with a very good fixation like this. And this is the way you have to use your own trick to see that you better do not complicate it. Very long back, I had got it from one of the companies, these locking nails. And those were the times where I was using a specially made nails where there is a threads inside the eye, and I was putting the screw. And this is the follow-up of that patient. She came after about 15 years. And this is what is good. Now, where do we make mistake? Here is where I have made mistake. There was a massive swelling, intact fibula, could not reduce well, wrong decision, pain persisted because nail is now not allowing the apposition of the fracture. Although I thought that it is an accident indication, but it is still so much dangling at the proximal part. Although at the same time, patient was feeling well. Patient has never complained unless except pain because it was too early to look at the. Then I said no. Let me put 2 screw. Let me make it more stable. And again, I was wrong because this is the wrong decision. Even when you have put 2 nails, it was not sufficient. Then I put the 3rd nail to increase the stability. I added 2 interfragmentary screw. Then also, as long as there is a nail, there are nails, it will not allow collapse. So these are the cases where the proximally in the lateral view, the fracture line is much near the joint. They are highly unstable. So please be careful. In this case, ultimately I opened up, I removed everything, and then I switched over to the classical plating, and I got fantastic result. So these are the cases where, because it was after almost 6 or 8 months, I changed over to this particular pie, waited, and nothing happened. Another, the problem which I have found is a Z effect. Look at the first X-ray, a fracture. Look at the second X-ray, very well healed, very well healed. Even after healing, even with all functions, the nail has migrated up. And these are the cases where you have to just remove it, as I showed you. But there are very few cases where there will be problem. Now, regarding the extended indication, this was a fracture which has happened at the end of the plate. Patient had with so many more comorbidity, So we wanted that since the first fracture was not healed completely and he had a second fall, so removing and putting a big plate is again a problem. So what is possible with this skin? The skin is not that healthy and number of problems. You can pass enders through and through the screws. It is a versatile implant. Only thing you pass either 3.5 or 4 mm. Don't pass 4.5 mm. But you are able to pass even with this and you can get away with such problem. So friends, very important thing is that select ideal cases, learn and expertise. There is an amazing micro motion which works and it's one more good options. So I thank you very much for this tibia. And if Navin, if you allow me, let me finish with the humerus also.
Finish it, no problem.
That
No
would
problem.
be that would be much easier for
But
us.
little faster so that there are
Yes,
some
yes, I know.
questions. There are some questions, and we want to put one or two case also of this.
Okay, okay. Now let me go through the humerus. Humerus is not very long. It is not very long. But
Please.
let me
So
just
you,
put it back.
more importantly, you show the technical parts.
Yes, sir. Yes.
That is what I said, that everything takes time, but you have to, fortunately, we are in a lockdown time. So you can see this, right?
Yes,
yes.
Okay, now, what Albert Einstein says, only a monomania gets anything do. You have to look and find out the solution because there are three types of surgeons. One is a slave of implant, another is using ideal implant, and the third which uses a single implant only. But friends, humerus fracture is most unpredictable. Whatever the method you use, it is not that easy because I found in my practice, humerus does not behave the way you think of. Now, regarding anatomy, there are peculiarities of humerus. It is having a medulla which is very much broad above, very much narrow below narrow. So it is not having a two expansion ends. And it is something like an absolutely cone, which is a very long cone. Now, this is the first fundamental thing we have to understand for the humerus. So merely lifting the arm against gravity, humerus is subjected to 10 times the weight of the limb or 70% of the body weight. So you need a good stable fixation. What past worker has said? Pankovic was a master. In 89 cases, he said, used safely, effectively in selected cases. Only one union was there out of 89 cases. And in Israel, Jerusalem, 25 cases. And they also said everything is very good. No violation of rotator cuff, which is very important in interlocking. And excellent fixation in the multiply injured patient compared to interlocking nails. Japan, 1993, undernailing 10 cases, all very good, no non-unions, no infections. Then Baroda, there is a very good paper, 59 cases. They also only one non-union. Then Patna, Bihar, India, they have got 50 cases with a comparison. And they also said that mean operating time and blood losses were more in plating than undernailing, and complication union rate were the same. So both techniques they found it is okay. Now let me go with the technical aspect. Lateral supracondylar ridge is an exceptional cortical long cylinder of the humerus, which is not available anywhere in the body. And with the same time, I will give you one comment that there are orthopedic surgeons who have lived their whole life. They have never ever experienced the elasticity of such nails. They do not know that there is a different instrument or different implants is available in the world. And that is the reason why I would emphasize again that anatomically in this case, there is a cortical ridge on the lateral supracondylar ridge of the humerus. So there is a sword-like grip when you put something from the lateral supracondylar ridge. And you have to make a drill hole through and through this cortex. You have to make your own tunnel. There is no module available, but this tunnel is going to communicate with the medulla of the humerus. And this is how you put the first nail. And very important that you pass the second nail from the above. And most important part is that whenever possible, pass the third one as well, because we need stability, because it is a humerus where there is impregnability. Now, very important point which I want to highlight is a distal acute band. So what are the modifications which I have done? This particular distal band, which is at 5 mm band, which is again straighten up when you are pushing the distal end, and then it has its own elasticity, so it has a press fit hold, and that is the reason why fracture will not distract even with a gravity. And this is something which has worked in my cases wonderfully. So this is very important. So look at this particular case. There is a fracture which is a transverse. You picked up a very good cases only. This is the drill tip pin which has been passed. Over that you pass a drill, a cannulated drill, and then you make, this is the cannulated drill. So you are making a big tunnel, and this is epi, this is lateral view, and then you pass the first nail, try to reduce it, and then because you have bent it as, you are able to get this particular reduction, put it on the medial side, then you go with the lateral side just distal to the greater tuberosity, you put this particular nail, and then when you, before you pass the third nail, you catch hold of the first nail so that it should not go inside of the deltoid muscles with a towel clip, pass the third one, and finally you try to put it in all the best places with a very good lower end fixation in epi and lateral view, proximal end in the lateral view. Look at this, full abduction of the shoulder, no impingement. And this is how you are able to go for an early mobilization when it is done in this way. So as there are the nails which I am showing you, the company which has given the nail and the nail which I have banned, which is S, and the second nail is C with a distal tip band. These are the very important aspect. So select sharp fracture transverse, short oblique, and axial stable. There is again one more point. This is the case. Look at this. Only one stitch above, one stitch below. And this is the way it fixes well because it is elastic and it is very well contoured. Only on 41 days there is a good callus because it is a preserved biology. And at the end you can see fantastic union at the end of 1 year, because, and there is no distraction because the tip is bent, solid union, nail in situ, and you get full function back to whatever the veterinary work he was doing as a doctor. So full power, all muscles untouched in situ. No muscle is replaced by the implant. This is very, very important. This another case, callus, which is seen on 45 days because of the best placement. And this is the case where again you see a very good union with the two nails which are bent properly, and you can see that patient is having absolutely normal movement. And this is what is at the end of 6 months. So there is always a time taken, but once it heals very well. Then this is the case where it is a little distal to the middle half, where here you can see this is the entry point. You pass the first nail, and then you go up to the medial side by rotating it, and you pass the second nail, which is just from the proximal side. Try to make all negotiation, rotate it and put it inside, and then at the end you have to pass the third nail. This is the proximal part, this is the fracture side, this is fracture side in all different views, and this is at the lower end. And this is how is very important. Now here, if I can show you, just a moment, there is a one good I don't know if this is working. I don't know, just a moment. No, this is not there. Okay, there is a video which shows that how I turn the nails. But now with the clinical side, this is the incision which I have made. Then again, I use 605 metal drill tip pin of 3.2 mm to make the canal in the lateral condyle, over which I use cannulated drill so that canal is sufficient enough. Now this is the first S nail which has been put, and that S nail has to be properly bent so that you have a best press fit part of it. And this is, look at this, where you can see that there is a good S which is to be introduced from the distal side. And there, if you see very carefully, when you go up to some level, then I start rotating it because it is an S. So my tip has to go to the medial end of the head of the humerus. And also preferably little bit posterior band because it is retroverted humerus. So you have to take care of this. And this is the way, once you try to finish it up at the end, you can rotate it and you can make the best negotiation through this. These are all minor things, but once you see somebody doing, you understand multiple aspect of this particular methodology. But there is a press feet, and this is where you try to first mark out the proximal end, see that this is the end through the IITV, just make a stab incision and try to go, if possible, through some of the, one of the raphe of the deltoid. If it is not possible, it's okay. With a make a very gentle and very soft sort of a way, go up to the bone, and then you make a drill. Usually you don't require drill in any of the cases, directly all will go, because proximal part metaphyseal is always soft. And here we just try to push it, and there also I'm trying to make as near as possible, and there at the end I try to see that some part is left, and then I use a different tool to put the final part which is not having a rotatory arm. And that is the way you can go with the final aspect of this, right? So these are the cases where you have to go on to and fro. Now you push from the proximal side, you push from the distal side, and that way you get a better fixation. At the same time, you get a completely buried or sort of a proper length of the nail, so that it does not interfere with the elbow or shoulder. A stitch above, a stitch below is the name I have given to this surgery. Look at this. They are able to do even rotation on the second day. Hello?
Yes, go ahead, go ahead.
Okay. Now, this is the final result. Look at, something is coming in the middle, the host is unmuted. Okay, right. So you can see the fantastic healing with a fantastic, the functional element. Another case, 10 weeks, you can see the callus. These are the extended indication, but there was an old fracture in this region, and there was a fracture of the lateral condyle of the humerus as well. So we fix it with an open short plate, and by the side of the plate I have put two nails. And he also had an old olecranon fracture which was still not united. But this is the way you can pass nails because they are flexible. When you have a dense medulla, you can think of upper third humerus as well, because the fibula is dense. The medulla is dense, so you have a very good hold intramedullary. This is another case where it looks, but when you see, you can fix it very well. But if the implants are not from the good company, or if your push or hammering is not okay, then you might bend the eye at the superior end. It does not give much difficulty, but sometimes it creates a bursa. You can accept such minor angulation. Now this is the case where fixation is done and he is able to do all movement next day only, because three nails have been passed, one S nail and two C nail, and the second nail with a deep distal band. All these things works a lot and you are able to get a good result. Now another case where you have to see that, can you make it axially stable? If you are able to make it axially stable, you can go ahead with the under nail. And in such cases where there is too much of soft tissue injury, you are afraid of many things, then a stitch above, a stitch below is a good surgery where you can go away with this, and at the end of 9 weeks there is a good callus which you can see. Now this is another case. This is the case where I have done hybrid. There are case available, the studies available on internet where you can use hybrid. If you feel like the third nail you are not able to pass as thick as you wanted, then you can pass a thin 10 nail, but it will add on to the stability. So you have to think of in each case and try to get best of it. This is the fracture which is at the lower one third with a radial nerve palsy, and we are always afraid of this thing. So here we have made a drill, then you widen it, that particular canal, over that drill tip pin with a cannulated drill. You pass the first nail, and here look at very carefully, because of the S, I am pushing it and I'm also turning it. And this is the way you are getting a very good anatomical reduction, because the nail shape, the countering is like this. And this is how you go on doing the rest of the job. And at the end, you are able to do the best of the fixation, and you can check in all views that everything is satisfactory. And even the abduction at the shoulder is not impinging everywhere. And this is how the post biological smart fixation will look like. And here at the 28 days, there is some recovering of the radial nerve palsy. And I know that at the end of 8 weeks, he had some extension of the wrist. And there is a radiological sign of union, although it is not fully united, because still patient is under follow-up. So this is the last case, which is very important. Can you think of undernailing in such a long oblique? Yes, as Navin has said, if there is no buttonholing, if you know that you are able to reduce, so, reasonably, then you can go ahead. So in this case, as a protocol, check the joint above, check the joint below, check if you can do a good reduction, then drop your operative procedure. If it is not a good reduction, go ahead with the operative procedure, pass the first nail by this pin, pardon it up. Now this is very important. The default bands which is given and the given S contour, which I have shown on the second slide, use 3.5 mm for the humerus. So negotiation is done like this. Now when you go into the proximal fragment, every time you are not sure, you might come out. Don't worry, you have to understand more and more, and when you withdraw it and just rotate it, you are able to put it back inside, and that is how with the S you are going to get better and better reduction with a second nail, with a third nail. And this is the way you try to bend the second nail, which is a C-shaped, which is bent quite more for the entry with a distal tip bend. And this is second nail which has been fixed. So final check is like this. You can see all these things in all the different views. This patient was young enough, so 2 nails have worked. Only small stab incision at both the side. And this is what the healing in the peri and post-operative, and this is how the healing at the end of 1 month, very free movement they are able to do, although abduction is not allowed fully because it's only 1 month, 4 weeks only. At the end of 10 weeks, this is the union in progress. And look at this. Finally, at 1 year, no shoulder problem, no elbow problem, and only 1 stitch above, 1 stitch below. So there are cases where I have come with a complication. This is the case which was done as per all my expertise and this thing. But as I told you, humerus is unpredictable. So everything went well, but for 2 years, no symptoms, all function good, but X-ray doesn't show union. So these are the cases where sometimes we have to do something else. One more case where some local companies' nail were used, which I, after doing the surgery, I sent it for the laboratory test, where there are all chances that it can break. But here, very important point is that when you have not a proper metal and you jam the canal, then this is not the canal which is having a broad end both sides. This is the conical canal. So the distal part is fully jammed and the proximal is not jammed. So at the fracture site, everything will break, which we have seen in all femoral component of bipolar, where the stamp is broken because the distal stamp is very much fixed. The proximal part is moving much in the same way. So in this case, there was no way because it was very old. So we put the interlocking nail. So friends, at the end, all this analysis, I have got something very important to tell with you. Learn the technique to your satisfaction first. It looks less acceptable till you practice, experience, and master. Clear all your doubts. Many modifications and add-ons are introduced. Don't think of the old part. Do thorough and sincere pre-operative planning. Document pre-operative status. Counsel the patient and relatives. All implants hold better in good bone stock, less in osteoporosis. Very simple. Additional portable X-ray machine in operation room is advisable. So many times you are not sure, so you need it. Keep alternative fixation material always ready. Don't think of this one methodology will work. More than that, what is very important is that duration of operation is not only a criteria. You need to do good job, achieve and maintain best of the reduction. Precise bending of the nails for press fit fixation is essential, not necessarily not good, it is essential. Ensure proper size, placement, number of the nails, attempt more if required, leave no gap at the fixture side, confirm by x-ray when in doubt. Don't think of your old age IITV, you have to check it. Document operative remarks, which is very important for the next. Ambulate when pain subsides. Weight bearing is not the only indication of good fixation. Every time you don't talk about weight bearing, ambulation is very important. This is generalized for all undernailing. And consider removal of implant as a major surgery. Do not think of. So again, one more time, I just say that this particular video is available. And at the end, science. What is science? It is a bio nature. It is an adaptability. Science has to stop somewhere. Because look at the high tension electric wires, where tree has found out its way. The biology finds its way, and it has grown across the whole high tension, high voltage wires. So what is very important is the factual observation, because you are not able to give good explanation, but you see the final result. You may call it as a miracle, or you may call it as a magic. So I thank you very much for this listening.
Thank you, Jawar bhai. There are questions, Jawar bhai, and I'm showing you one case also simultaneously. There is a question that whether you fix the fibula first in the tibia and then put your this flexible nails.
Yes, because you want to maintain the length. The principle is you have to see that at the end of the surgery, it has to be axially stable. So how do you know the length? If you have a chance to fix the fibula, then you know that at least you know what is the good length of the tibia.
Yes. Okay. Now I'm putting a one case and putting you on the question mark little bit. What will you do in this humorous case? Dr. Rahul Katta, sir.
Yeah, I'll do the open reduction internal fixation with the plates.
Internal fixation with the plate.
Yeah.
Dr. Sivasankar.
I want another view.
Another X-ray is definitely yes.
Another X-ray is not there, but in AP there is. This is the lower segment. This is the lower segment.
Yeah, probably it's too difficult to treat with a nail. I would like to treat with a plate.
Okay, Kashyap bhai.
Plates. Plate and 1 or 2, maybe.
Dr. Ashish.
Plating, extra-articular distal humerus plate.
Any other opinion?
I think it is much comminuted, so it will be difficult to handle once you open it. So I would go with the technique by which we put a small incision on the both sides, and from both sides we pass flexible nails.
From both sides?
From distal end.
Both sides?
Yeah, medial and lateral both.
Okay, medially there is ulnar nerve also. You have to take care
of
the
there is no problem. We can open it, we can see the nerve, and we can isolate it.
Okay, let me show you.
Dr. Jigar, it's an axially unstable fracture.
Let me tell you that we have some surgeons over here who have shown excellent results in so many of such cases where we have much comminution there, but with that fixation, because there is much of the metaphyseal bone in the distal fragment that holds the nails very nicely, and that gives very stable fixation, and it gives very good result.
I am not in favor of flexible nail, but even if we fix it with the flexible nail, we can put an add-on external fixator.
We need to see the AP view.
You feel that flexible nails alone will not do, right?
Because axially it is compressible, so it's better if you add on a JES or something, even simple one pin fixator on either side.
For initial 3 to 4 weeks time till the time fracture gets glued.
Once you are putting the fixator, what is the need for putting the flexible nail inside?
Yes.
Treat it with the fixator itself.
No, but fixator
cannot be there for a very long time.
You can treat this fracture with the jazz fixators as well. There are people who are showing the good results with the jazz fixators.
Jawar bhai, is there a role of flexibility of the nail to have a multiple contact points?
Yes.
It depends on the multiple contact points and stability with the flexible nails.
That is what I said. 30% of cortical absolute intactness, and you get an axially stable lateral reduction. Then only you think of nail, because you need something where further collapse is not possible. Secondly, these are the cases where you have another view, where you have some 3D CT. You might think of that it is possible to go away without plate, but commonly in such cases, the first thought will be extra-articular posterior lateral plate.
Okay, let us see what happens. With the new flexible nails we have developed, we tried, this is the first flexible nail from the lateral condyle. Then this is the second flexible nail. And due to adaptation and multiple contact points, it got gradually reduced. You can see it is the nails in the different direction, multiple contact points, 3 flexible nails, and it is very well reduced. And this is the small incision here, and this is the follow-up where you can see that it is a good buttress here, good buttress here, good buttress here, and these has a good buttress here, good buttress here, even though it is put from the one side only.
Sir, why not from medial side? Why not from medial side, just to avoid late ulna?
If you get from the one side good contouring with the flexible nails, it is the metal which differs. This is a different metal totally. A construction of the metal is totally different. It is too much flexible. At the same time, it gives multiple contact surfaces, not the contact points, multiple contact forces in a multi-planes.
Yes.
That's why it is giving us stability.
Navin, what is the thickness? What is the thickness of these wires?
All thickness is 2.5 mm. All three are of 2.5 mm.
Titanium tensed nails, na?
No, it is titanium. It is not titanium tensed nail. It is
special nails from
still. It's a
Navin Thakkar. Navin
Thakkar's nail. So now
it's not Thakkar. It's Thakkar.
Navin's nail. So
one more comment.
And this is also a possibility. Flexible nails can also give us stability like this.
Now,
so only thing is you must have to get the multiple contact points and multi-plane fixation with multiple surface area contacts.
So now my one point is, when you pass multiple nails which are contoured, so don't think of that something is centrally placed. So
yes,
there could be collapsibility. Something when it is
it is not a canal filling.
Yes.
It is not a canal filling. It is not a canal filling. Yes, it is totally a different concept. A different concept.
Yes.
Now another case. This was the polio patient with the proximal femur fracture and distal femur fracture. I treated simultaneously. Distal was open with the polio almost fused knee. Now after 5 years is the second fall. What will you do?
Ender's nail from medial aspect.
Oh, now you came from the enders. Only enders will do. How will you pass the enders?
Yeah. Beside the screw, we can pass the enders, not an issue.
Here,
one from the medial side, one from the top.
But here, the canal is very narrow. You see, you do not have a much place to go in between the screws. Yeah. When your canal is normal, without non-polio limb, it is possible.
Sir, remove the distal plate and then put enders.
Then put only enders?
Enders and for polio, again, additional external fixator for 1 month or so if needed.
Kashyap bhai?
If I am removing the plate, then I will put a plate again.
This is a transverse fracture, and in a polio limb, there are no much muscles acting on that. So I have burnt my finger with this, putting 1 or 2 enders. I would probably remove this distal plate and put a longer plate with the spanning screws.
A longer plate up to which you will put?
I'll go
plate up to here.
One screw above the superior plate.
One screw above?
Yes.
So you have to remove these plate screws.
Distal I will remove. Distal I will remove.
Distal you will remove. Then
Yeah.
what will be the length of your plate?
Probably that will be, if I can cross
Here,
it,
here again, up to here, up to here.
Yes.
Then
yes.
again it will create a stress riser like this.
That's correct.
But that is the problem area with the
because then you can remove 1 or 2 screws from the proximal plate and overlap the plate.
Okay, fantastic idea. Rahul ji, any idea?
Sir. No, you have to put another plate. Simultaneously, you can augment it with the intramedullary flexible.
Yes, that's what
that
Navin Bhai would have done.
Perfect thing for this patient.
That's what Navin Bhai would have done, and that's what I think. Ender augmentation.
Medial Ender's augmentation.
Flexible. Yes. These are again a flexible nails from the lateral condyle only, and I augmented with a long plate and 2-3 screws overlapping both the plates, so that there is no area which is left unprotected.
Yes.
And this is the follow-up, and this is showing good, because previously also it was very difficult because the neck was very difficult. I had made a customized plate, T-plate, customized, and put a screws 150-degree into the neck, where it was very much antiverted and it was a high valgus angle. So I was not keen to remove that plate.
Sir, how it was possible for you to put the plate over that plate, or you have put just by the side of the previous plate?
No. It is over the plate. Screws are going one plate to other plate and the previous holes only.
Okay.
Yeah, you can see on the X-ray on the right side, we can see the overlap properly.
Complete overlap. That was the difficult part, but that was required to have a no stress riser.
Yes.
Excellent.
So the flexible nails can act as an augmentation for such a polio patient. And this is the 4 months now post-op, and he's walking. He had already a hand-to-knee gait. See, he's walking very well. Just now I got the video today only.
Navin bhai, only one question which is coming in my mind in looking after the tibia and the humerus. I just want to learn from Dr. Shiva whether he wants this much of callus which was shown on the X-rays in all his patients. So more callus means good union.
Yeah.
That is not the conventional teaching to me.
More callus means there is a micro motion. If it is a too much of motion, there will be irritable callus without union.
Yeah. Will be non-union.
So what is the comment of this, sir?
Yes, I tell you.
Whatever it is, earlier we were all talking about absolute stability and primary bone healing. Now we all talk about relative stability and secondary bone healing, and definitely relative stability with good callus is that's what I would aim for. So even when I do interlocking nailing, I always do dynamic locking so that I will get some axial micro motion like Elizero, and I never do a static locking even in
but sir, even in the dynamic nailings you are not having so much of the callus at the fracture ends either in the tibia or femur or humerus where
the technique has to be reviewed because there cases will be different, but dynamic.
What Dr. Ashish you would like to comment on this much of the callus at the fracture ends with micro motion?
It actually depends on our intention. Looking at the X-ray, we just have to think about whether we want primary union or secondary union.
And whether we want an absolute stability or a relative stability.
So in case we are seeing callus in absolute stability, then that's a disaster. And if in case we are not seeing callus in secondary union, then that's a disaster.
No,
so
yes, very important point is, don't think of this small part. Look at no infection, 100% union. Look at whatever good stability, good function. So more callus is not basically a problematic. One more thing which is coming up with a new research. I don't know whether you have attended the micromotion. Motion
stress and micro motion.
Motion lock workshop. My point is, a good research is going on that which flexibility works. Is it the axial flexibility or a rotational flexibility? And now I'm coming to some sort of a conclusion I will share in future, that it is the rotational stability which is more important, which is the part in Elizaro, rather than only axial. Axial is also good, but when you have rotational, the amount of callus is good. And I remember Dr. Divetia Sahib, he had a fracture of the humerus in Switzerland when we was doing skiing, and they put a plate, and he was all the time telling me that better would somebody who have done nail, because this plate had gone for primary union, but I have lot many problems in finding out whether there is union or not, and I was not as happy. And now Switzerland also is thinking of some amount of callus is a good indication to see the progress of the.
Yeah, that there is an excellent study which talks about a locking plate for distal femur and versus the suprafrontal or nailing, where they say at 12 weeks, hardly there is any callus seen on the opposite side underneath the plate. At that 0 millimeter against 332 millimeter with a nail.
With the nail.
So that's one of the reasons why they are coming out with far locking cortex, so that they have some axial micro motion even with the locking.
No, that's true. I agree. Micro motion must be there. That is the principle. But if you have too much of the callus, it is difficult even to judge whether there is a union or non-union. You have to go for a CT scan. Sometimes it is looking like there is a union, but inter-union is not there. The callus, which gives a false indication of the union.
If there is much callus and pain is there, then it is non-union probably.
Yeah, correct. Sometimes humerus it is very difficult because
but non-unions by definition are painless.
Yeah. If the patient is painless and he is doing all activities, then I'll wait, even if the X-ray is showing gap.
Yes, sir. I have seen after 3 years even the fibrous tissue is converted into bony tissue.
That is correct.
All surprises are there in humerus.
And sir, in humerus only, Dr. Hemant Mandova has sent me a case where his own case at 3 years came back with all 3 nails broken. So that also is happening sometimes with enders, particularly in humerus. So humerus sometimes is giving funny and unpredictable results.
Yeah, that's correct.
Dr. Jawad Jetwa, he said that in place of enders nailing, you have put, they have probably not understood the principle. Even the rust nails would have done the same results. That is the question.
That is how the metal, the contouring, the maintenance of the contouring, the banding.
Technique.
Why rust nail? Because rust nail is not with that metal. Rust nail is not with that particular band available. Rust nail is not with the eye. So a number of things you cannot rotate the way you want. And secondly, all this which we are using the nails other than ender metal, all these nails can bend anyway, and it is not going to spring back to give this press fit force. So that is not the thing which you can achieve.
Now there is a very good question. Very good question. Why there is no much research or study on bends of the ender's nail? Whether it is a commerce which is affecting ender's nail to get developed?
Okay, now I give you the answer. Number one, this was my question. So I did all these modifications in last almost since 2007. So this is where students of science will try to find out which way we can do. Secondly, why it is not available? Because as long as the manufacturer has not taken interest, none of the implant or methodology will be popular in any of the faculty of medicine. May it be ophthalmology or may it be gynec. The only thing which is pushed is when there is a business. So once a day would come, somebody would be interested, and you will see number of workshops and meetings going on with ender nails. But this is the problem with the methodology. But as an academician, yes, we needed modifications, and I also have come back to ender nail even only when I have found this modification by which we are able to see good results, and we ourselves can be convinced that yes, this is a good option.
Sir, another reason for that I would like to tell, because in last 10 to 15 years, it has been widely dropped in the institutional as well. So in the institutes, the new residents who are coming, they are not seeing ender nail very routinely. That's why it is not being practiced.
They even don't know the name of the ender nail. In exam, if they are shown ender nail, they will not identify that it's the ender nail.
Yes. So that is the most important problem, and that's why it is not being much popular. So that is the area where Dr. Ashish Jaman, you are in Safdarganj, and you must be playing a role as a professor.
Teachers must come forward.
Yes, so teachers can play a big role in this. They can start doing ender nail, and that will create an awareness amongst residents and then in the senior people as well.
Jawar bhai, now the new question has come for you.
Yes.
What is your post-operative protocol in humerus? What you have shown?
Tell
us one or two lines.
Yes, I have shown in the video. If you are confident you have done a very good job, day 2, you can start with the elbow movement in a supine position where the arm is resting on the bed, and you can have a little bit of motion, rotation. Now, very important point is at least for 3 weeks, keep a sling, because that is required. But with that sling, do not stop abduction of the shoulder. So how do you get abduction of the shoulder? Ask the patient to be in supine, then go on adding pillow in the armpit, and one by one you go on putting the pillow so you can keep it in abduction. So these are minor part when you see somebody is doing, and you be with that for 5 weeks, 6 weeks, or 2-3 months, and then you know what is happening with the follow-up, and all these minor points can be.
Oh, now the question is same. Is it a 3-point fixation or a press fit fixation?
As you said, you have said
multi-contact.
It is a multi-contact, is a linear, and it is a press fit because of the metal.
Yeah. Now again a question is from Nitin Patil is in the if the level of the fibula fracture is same with the tibia, what will you do? Fix the fibula first and do a tibia flexible nails or endo nail?
If the tibia fracture is such that I am able to reduce with a good axial stability, then I may not touch fibula. When there is a combination where I am not sure that I will be having a good axial stability, then to add on to that, because we have 2 bones, it is better to fix the second bone. Otherwise, we can leave it.
So now there are some comments only, better comments. Dr. Ninad Doshi has said that, thank you very much for this modified Enders technique for learning us. And there is a one comment for Dr. Jawad Jetwa from Dr. Srinivas Rao from Andhra Pradesh. Jetwa sir, heads off to you, sir, for commendable job.
Thank you.
So there are so many things are coming
definitely.
as a compliment to all the faculties, and excellent sharing of a lifetime experience and tips and tricks by Dr. Sitaram from Guntur. He is saying thank you very much. Many district level hospital people are saying that this is a good method for us in the district level setup, where we can do this easily with whatever resources are available with us. So it is a very fruitful webinar. Now it is 4 hours, more than 4 hours now we have gone through. It is 4 hours and 19 minutes.
Now time to dinner.
Yeah, it's a time to dinner. And I have to prepare. Tomorrow we have 2 webinars. One is on the distal radius, pediatric distal radius, 4 to 6. Yes. And then 7:30 to 9.
Dr. Navin Thakkar, my compliment to.
Thank you. And
Navin,
listen,
you are there from 7 to 1 with
and me. Some energy to Dr. Navin Thakkar.
Yeah, and 7:30 to 9:30, difficult implant removal with the very good faculty, Dr. D.D. Tanna sir, Dr. Siva Shankar sir, Dr. Deen Dayal, Dr. Ajit, Dr. Agase sir. So all good faculties, very good faculties with their treasure of their examples. They are coming 7:30 to 9:30, late night. But still people are asking, there was a demand, specific demand for, there is nothing written in the book, just like in the Enders, for implant removal, tricks and tricks. It is on-table decisions.
Implant removal will need 4 hours.
So it is 7:30 to 10:30 probably it will go, but 4 to 6 is a pediatric distal radius by Dr. Dhiren Ganjwala. It is a POSI GOA combined webinar. So thank you very much again to all the faculties who have stayed till last, and those who have contributed completely, and those who have, due to their various reasons, they had to go because the time was 4 to 6 only.
Thank
you very much.
Thank you,
Navin. So I am